Okay.
Lakshmi, ma'am, should we start?
Yes, we will start the moment. Yes,
Shri,
yes.
Shri, I'm just going to introduce you and leave you alone to run the show, yeah?
Yeah,
Just
just a second, Jyotsna.
just a second, ma'am.
Live and hand over to Jyoti. We will start. Yeah.
So, a very warm good evening to all respected speakers, panelists, and delegates. This is Firoz Khan from Walter Bushnell marketing team. We welcome you all to this wonderful session organized by Indo International Web Series. This is 11th in edition in association with RCOG Indian Legion, presenting a live webinar on theme preterm birth. We look forward to a wonderful scientific dissemination program today. So without any further delay, I would like to call upon to this virtual dais, Dr. Jyoti Malik ma'am, to take it ahead with this scientific session. Ma'am is currently Medical Superintendent, JJ Institute of Medical Sciences, Bahadurgarh.
Slide show दिखा दो. हाँ. Share कर लो screen. हाँ. उसी को आगे बढ़ाते रहो फटाफट. हाँ.
Yes.
Yeah, thank you so much. Thank you, Mr. Firoz. Thank you, Walter Bushnell, and welcome all the participants, all my faculty and the delegates today on a Sunday, on especially thanking you each one from the bottom of my heart so that you could make it on a holiday, and especially my international faculty. On a Sunday morning, you could take out your precious time to join us. Thank you so much.
And Jyoti, we are having 5 today from RILG who have joined us. So we are so privileged and honored to have 5 international faculties, Professor Andrew, Professor Anna, Lisa, who is the first one to join with me. Lisa, welcome. We have our own Jyotsna Pundir and Srividya is here. So welcome each one of you to virtually to our India. So thank you so much for joining us and giving your expert inputs on today's webinar of preterm birth. Yes, Jyoti.
Yeah, actually, we are actually honored, and I would thank Dr. Lakshmi ma'am, who's the convener and who has been doing such a great work for all of us, getting it coordinated, and with our international coordinator, Dr. Jyotsna Pundir. So can I please have the short CV of our, would you like to share? We have Dr. Next, please. Next.
Jyotsna ka dikhao.
Yeah. So Dr. Jyotsna is a consultant gynec specialist, reproductive medicine, minimal SS surgery at St. Bartholomew's Hospital, London, UK. And she has been the backbone behind the whole show along with Dr. Lakshmi. Dr. Lakshmi has been doing the Indian part, and Dr. Jyotsna the RILG part. So thank you, ma'am, and over to you to say a few words.
Thank you, Jyoti. You're very kind. You and Dr. Lakshmi started the whole show, and it's our privilege to be part of it. It's such an honor to again introduce Dr. Sridhya Shankaran. Extremely.
Slide dikha, madam ka? Yeah. Yes.
So she is consultant in maternal fetal medicine at St. Thomas's Hospital, and she's also honorary senior lecturer at King's College. And her passion is in the training of the next generation, and she has been a TPD for the Health Education England. But most importantly, coming from India, we were in the journey together as trainees, and it's such a pleasure to introduce her again. She is going to be the convener of this whole course today, and she has brought really big eminent figures in the world of preterm labor to this dais. Thank you so much, Sri. I'm going to hand over the platform to yourself, Sri.
And thank you, Jyotsna, for connecting me to Sri. And Sri, thank you for connecting me to Professor Andrew, Professor Anna, and Lisa. You have brought the real experts who have great experience on preterm birth. Yeah. So, Sri? Yeah.
Thank you, Dr. Lakshmi and Dr. Jyotsna Pundir. I think this is the second public meeting, but I have been following all the meetings you have been doing, and it's been extremely heartwarming to see how it's been received by everyone. And so thank you for inviting me today. And I think, Jyotsna has such a big trust on me, and she thinks I'm an expert on all topics in obstetrics. As it happens to all of us, as we go up, we become very narrow in our specialty. But, I'm very fortunate to be working with experts, who are the world leading expert, not just in the UK. And, having that, and also, as soon as I spoke to Lisa, without any hesitation, she said, yeah, I will put together. And I was quite thrilled when she managed to convince Professor Shannon and Dr. David to share their input. So I'm extremely grateful. Can we have the slides of Lisa?
Dr. Lisa, Yogendra, slide dikho.
Yeah, Lisa's Storey is an experienced obstetrician, and she has recently joined our consultant faculty at the Guy's and St. Thomas's. She has done her subspecialist training in maternal fetal medicine, and she has got a very unique expertise and research interest. Her PhD was on intrauterine growth restriction, and she did her subspecialty in maternal fetal medicine. And she has done a lot of research in fetal MRI and preterm birth. And she's making lots of advances in there. And in the next 10 years, what she does now is going to change the way we are going to manage and prevent preterm. And hence, it's with great pleasure that I would invite Dr. Lisa Storey, who is going to chair both the sessions today. Thank you, Lisa. And thank you.
Thank you very much, and thank you so much for inviting me here today. It's an absolute pleasure to meet you all and tell you about our experiences. I don't know if there's a slide for Professor Shannon as well. He's going to deliver the first talk of the session.
Yogendra, slide dikho. Professor Andrew ka intro ka slide dikho. Yeah.
So he really is a world leading expert in preterm birth.
Professor Andrew, speaker.
Perfect, thank you.
Let her introduce.
The chairperson, second chairperson, and or
Yogendra, piche ja. Professor Ballard ka slide dikho. Jyoti, please do honors here.
It is an honor to have Professor Dr. Ballard as well here. Dr. Ballard is a senior consultant, KLE's Dr. PK Hospital and MRC Belgaum, and he has been president of KSOGA 2018-19. So, sir and Dr. Lisa would be chairing this session, and I now request Dr. Lisa to please introduce our speaker, Professor Andrew Shannon.
Okay, so yes, Professor Shannon is really a world-leading expert in preterm birth. I've had the fortune to work with him over the last decade or so, and he really has pioneered a lot of the work to really try and predict preterm birth and really try and prevent the morbidity associated with it. He's really responsible for the use of fibronectin for prediction of preterm birth in the UK being rolled out nationally. And I'm sure he'll cover that in his talk as well. He also holds roles as the clinical director of South London NIHR Clinical Research Network. He's the chairman for Action on Preeclampsia, and he also has a significant global health research portfolio as well. Fantastic. So he's actually pre-recorded his talk. So I will share the screen and let him tell you all about prediction, prevention, and minimization of the morbidity associated with preterm birth. So hopefully you can all see the screen now, and I will start the talk.
No, this time sound is not there. Technical team, Yogendra, जब check किया तब तो आ रहा था.
Really based around
Yeah, it is there. Yeah.
NHS commissioning guidelines. There's been a recent government initiative with an ambition to reduce preterm birth rates from 8% to 6%. And this has resulted in a document, the Saving Babies' Lives version 2, which is available online to try and standardize the care of women who are at risk who come through our service. And the UK Preterm Clinical Network is a group of clinicians who have got together to develop guidelines and share practice, given that this is a relatively new area with a lot of new innovations with prediction and preventing preterm birth. I was one of the authors of the Saving Babies' Lives version 2, and I'm also a founder member of the clinical network. And this is a group that I was asked to chair for the government. You can see here, really with the ambition to deliver this quite ambitious target of reducing preterm birth. And it really came about because, quite rightly, the maternity services realised that stillbirths and deaths, morbidity in small babies was a big issue. But we were able to lobby them and convince that reducing preterm births was a really important slice of this case, because a huge number of small babies do die and a large proportion will have serious long-term problems. Preterm birth is one of those areas which is pretty and interventions. So it is a really important area that has only relatively recently been got the sort of attention it needs in terms of what we can do to improve outcome. And it's a very expensive issue. In the UK, it's been calculated that if you can just reduce preterm birth by 1 week, so that's not just preventing preterm birth, but just shifting it, a bit later for 7 days, you would save approximately £1 billion, which is a huge saving and I think justifies any effort in this area. And it's worth just reflecting for a moment on health economic studies, which I've put together here, looking at the costs, for example, in the UK to the NHS of treating these big public health problems like obesity, smoking and alcohol. They run into the billions each year, but actually preterm birth is comparable to them. And I think we sometimes forget a small subsection of our specialty actually attributes to a huge proportion of healthcare costs. And this particular statistic is only in the first year of life. If you look at the statistic for, long-term morbidity, cerebral palsy, I suspect that preterm birth is even more of an impact from a cost economic point of view than smoking and alcohol and so on. But obviously the emotional and the psychological and the personal impact of this condition cannot be overstated. So I wanted to share with you what came up in the Saving Babies' Lives 2 care bundle. It basically concentrated on a number of elements, the fifth of which was preterm birth prevention. And one of the key things to remember about preventing preterm birth is you don't have to stop it and get to term to make a big difference. And because of the improvements that neonatal facilities have in recent years, you can see this paper illustrates that in the high income setting, that if you can just shift preterm birth from 25 to 27 weeks, 27 weeks is still incredibly preterm, but you can see how the morbidity and the survival radically improves at these relatively early gestations. And unfortunately, we haven't really done the research to look at these endpoints. We tend to concentrate on 37 weeks, 34 weeks, but it can't be understated how a relatively small difference in days in utero makes a big difference to outcome. Having said that, it's also important to recognize that preterm birth across the spectrum matters. So even preterm birth, late preterm birth after 36 weeks is associated with problems. And the chance of having a sort of need for special needs, for example, in school is considerably higher at 37 weeks than it is at 39 weeks. And it only kind of improves really up to 41 weeks. So it's just simple things like when you're making decisions, should a baby be delivered early for relatively soft or less serious conditions, you are potentially increasing their risk of having problems just because they're a little bit premature. Obviously, this data is a little bit confounded by the reason you're being delivered premature, but nevertheless, I think one has to be cautious about just saying, oh, well, delivery after 32 weeks is safe, because those babies are far more prevalent and they do have morbidity. So just considering for a minute what we might do to make a difference. In my clinic, we are relatively simple in our approach of risk assessment. We take history. We certainly look at psychological issues around preterm birth. We measure a biomarker, in particular quantifiable fetal fibronectin, and I'll talk a little bit about this. And we measure the cervical length. And this approach actually allows us to triage and identify a huge number of people who are at risk, and perhaps even more importantly, exclude large numbers of women, reassure them who don't need that specialist attention, and frees up services and reassures a lot of women who've had previous adverse events. We do a lot of research, and this just gives you some insight in the sort of things we're looking at: the vaginal microbiome, other biomarkers, genetics, MRI, cervical integrity. Because this is a condition which has attracted a lot of attention, there's a lot of unusual interventions out there that have very little evidence base, and huge numbers of women I see will be getting treatments and tests that are simply not supported by any evidence, things like natural killer cells, thrombophilia screens, TEGs, assessments. And because women are desperate to have something done, clinicians are very keen to help them. There is this rather perverse sort of vicious circle of supporting these unevidence-based interventions. And most women do well in spite of us, so then they carry on being used again and again. And I think it's really important that we look at this critically from an academic perspective, and clinicians only take on things that are have an evidence base. With interventions, cerclage has been around a long time. We're increasingly using progesterone. I'll talk a little bit about these interventions. We do refer to services that help, like domestic violence, smoking, drug use. We obviously give education to the women. There is a role for antenatal steroids, admitting people to time critical care in an appropriate way, and we give psychological support. We're looking at other interventions, including the Arab and pessary, access, particularly midwifery models of care, and pre and anti-antibiotics. Again, there's a whole bunch of interventions which have very little evidence-based that are commonly prescribed, everything from steroids, heparin, and some of these can actually be quite harmful, and I think we need to look critically at whether these really are making a difference. And the problem is preterm birth is this condition which has multiple etiologies. It would be important to not leave out this issue about the mental health around this condition. Women have unbelievable anxiety related to poor previous histories, and we do routinely ask questions around the symptoms, particularly around depression, anxiety, and we can refer people to the appropriate services to deal with these issues. And there's a lot of research going on about how this actually impacts on their future outcomes as well. But the key message today is that we should think critically and carefully about why people go into preterm birth. And there isn't a one-size-fits-all in terms of prediction or prevention. So this slide, I think, says it all: think, 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 and you can consider exactly what it is you're doing that has an evidence base, rather than just because you've done it before. I'm going to divide the rest of the talk into the three elements described in the Saving Life Care Bundle: prediction, prevention, preparation. Obviously, prediction, we can take a history. There are multiple reasons why we go into preterm birth, and a careful history will often elucidate these. And I won't share all these with you, but they're very nicely described in the Saving Life Care Bundle outputs. You can see here who we deem high risk, who we deem intermediate risk, what historical features they have, and importantly, we give recommendation on how often they should be seen and what sort of interventions and management they need. We know, for example, things like taking chunks out of the cervix for abnormal smears will increase the risk of preterm birth by about 70%. We now know that people who have cesarean sections have an increased risk of going into labour early if they have a cesarean during labour. And you can see from this paper from Levine in the United States, very nicely shows how risks of subsequent preterm birth increases with your previous emergency cesarean. And the mechanism is quite straightforward. During labor, the cervix gets pulled up over the presenting part, and instead of cutting into the lower segment of the uterus, the surgeon inadvertently is cutting into the cervix. Very difficult to see anatomically. You don't know. You obviously have to do this to get the baby out safely. But this damage is known now to increase the risk of preterm birth. Here is a histology specimen of a woman who's had a previous scar from this, and it's this defect that seems to be the cause of the problem. We can actually see it on scans where you see a niche. I just want to show you the impact of this. This is a paper we recently published demonstrating that if you've had this problem of losing a baby after an emergency cesarean, the chances of having a subsequent problem becomes much higher. So normally in my clinic, if you needed a stitch because your cervix has gone short and you've got a poor history, you do pretty well. Only 3% of people deliver before 30 weeks. However, if you've had a cesarean section as the cause of your preterm birth, the risk is much higher. It's almost 1 in 2. It's about 10 times higher. And whether it's in a cesarean section full dilatation or even a cesarean section earlier, if it causes a preterm birth, that preterm birth will be recurrent, it'll be early, and it'll be difficult to treat. And we are only just doing the research now to try and work out, one, how to identify this problem in people who haven't had an adverse event, and also what interventions help, for example, abdominal stitches. The big tool for predicting is cervical assessment. There's also biomarkers available in the UK now. Most units now use fetal fibronectin as a biomarker. There are others available, Partis Short Actin Partis, but fetal fibronectin is certainly the commonest and perhaps the best. We know the cervical length, as it gets shorter, increases the risk of the chance of going into labour. We know that if you take a fibronectin test from the cervicovaginal fluids, if it is high and positive, that needs to be over 50, you have an increased risk of going into labour, both in women who come in with contractions or in people who've got risk factors. And there's now quantifiable fibronectin being developed. So instead of just being positive, negative, you actually get a number and a concentration. Now, what about these tests? I just want to show you one example about why this think is so important. In a subgroup of women who have a risk factor for preterm birth, in this case, congenital uterine anomalies, we looked at just over 400 cases, and we looked at the ability of the cervical length and the fibronectin to predict whether these women were going to labour. And very interestingly, even within this subgroup of quite rare congenital uterine anomalies, depending on the defect, the tests work differently. So resorption defects, the prediction was pretty good. So if you have an arcuate uterus or something like that, you could rely on these tests. But for fusion defects, things like didelphes, bicornuate uterus, these tests were not so good. And even it just means that the pathophysiology is different in these subgroups, and therefore the prediction tests work differently, and the interventions may well work differently. So this is just an example of why we have to kind of consider carefully what the causes are of preterm birth. When you use these tests, fetal fibronectin and cervical length, together, you can get really good prediction about who is going to deliver in the next 7 days. So women who come in and threaten preterm labour, if you combine a high level of fibronectin with a very short cervix, you can predict nearly 100% of the women who are going to deliver. And overall, fibronectin is probably a little bit better than cervical length. When we use this in clinical practice, what it means is we can triage and really identify the people who need to be admitted. And NICE currently say you admit everyone without these tests, but if you actually use these tests with a 5% risk, you see you tend to admit people who need to be admitted, and you send most people home, which in current guidance you wouldn't send home. So that's really useful. And how do you remember, combining these tests, the length of the cervix, the degree of fibronectin? Well, we've developed an app that does it for you, because there's obviously a lot of maths and calculation that goes into that. And essentially you can download this app from the internet, you put in your cervical length, you put in your fibronectin level, and it'll give you the probability of delivery in the future, either by in a week, 2 weeks, 4 weeks, or before 37, 34, and 30 weeks. And we even have displays to show the women to give them some feel about what's going on. This is now being recommended by NHS England in the Saving Lives Care Bundle Appendix over COVID, where triage and getting women into hospital appropriately and keeping them out of hospital when they don't need to be there was obviously highlighted with all our COVID practice. Not to underestimate the importance of reassurance that these tests have when people have lost lots of babies, they get told they're going to be okay. That has enormous value. When we've used these tests in our clinics, we tend to admit based on high risk, we send people home based on low risk, and our studies have shown that we do this pretty accurately. So in over 1,000 high-risk patients who weren't admitted, their chance of preterm birth is pretty much background risk, whereas those that get admitted, we're worried about 1 in 3 of them are being delivered seriously early. So how do we prevent preterm birth? Well, there's lots of elements in the Saving Lives Care Bundle care package, which I won't go into in this talk, but I just want to concentrate on the interventions: cerclage, progesterone, Arab and pessary. FIGO, I chair the FIGO Preterm Birth Committee, and we've recently come up with a number of guidelines about what is recommended in these areas, and I would encourage you to look at these. Essentially, stitches have been around for a long time. We do recommend that if you've had a previous history of preterm birth, then a history indicator cerclage should be offered to women who've had a number of these, like 3 or more preterm births or mid-trimester losses. Obviously, there are many women who've only had 1 or 2 losses who are very worried and what need to be managed. And a really nice way to deal with them is by doing cervical lengths. And if it's less than 25 millimeters, we now recommend that a cervical stitch is given. So basically, if you are low risk from a test, you don't have to do anything. If you're high risk, you should follow evidence-based practice. Progesterone is a new kid on the block. It's now being used increasingly, and following meta-analysis, it's now recommended it should be given to quite a lot of at-risk women. It has a number of mechanisms that you can see here about how it works. The FIGO recommendations say that you should give progesterone in the form of vaginal progesterone or even hydroxyprogesterone injections in women who are at high risk. The benefit is most significant in those who had a prior history or a short cervix. So either of those groups justify having progesterone given from, say, the first trimester onwards up to 34 weeks. If you happen to have a long cervix, then obviously that's reassuring and the effectiveness is not going to be so clear, and therefore that might be a reason to withhold progesterone because of giving drugs unnecessarily. For those with unselected multiple pregnancies, progesterone therapy is not recommended. All the studies on twins have not shown it to be beneficial. But there's no evidence of neurological or developmental benefit or harm in babies who have progesterone. So actually we can be reassuring that it's not going to cause problems in the future. And directing these stitches, so I just want to show you this slide, directing stitches to women with short cervixes seems to reduce the risk by 50%. And combining stitches and progesterone is still not is uncertain, but people are starting to do this. Now, I just want to share one of my trials, the Maverick study, where we randomized people, this is now actually published in the American Journal of OMG, into receiving an abdominal stitch, which is a laparotomy that gets the stitch much higher in the cervix, in women who've had a stitch before, but it has failed. And in these women, they are much more likely to have a successful pregnancy with an abdominal stitch than with a repeat vaginal stitch, whether it be high or a low vaginal stitch. The numbers needed to treat are pretty impressive, less than 5, and that is both to prevent a seriously early birth before 32 weeks and to prevent a baby death. And the FIGO recommendations now are that in women who've had a failed cerclage, and that means by definition someone who's delivered before 28 weeks, they should have an abdominal stitch. If you want to see the procedure, we have published this in the MFM journal. You can go to the website and watch the video. And I've actually had people in Africa who've copied this video or seen this video and done this procedure very successfully. I just want to give you an example of a woman who came to us in one of these trials. So here is a typical woman who has multiple losses. She has a loss at 16 weeks, 17 weeks. She gets a stitch in the third pregnancy, but still loses it at 23 weeks. So she gets randomized in the Maverick trial and gets a high vaginal stitch and still loses the baby. So having lost 4 babies, and she's now outside the trial, we said, well, why don't you try the abdominal stitch? And it works. And it works again. So this is really strong proof in a crossover way that this stitch works well. So in all the women who lost babies in our trials, having had multiple losses, so that meant they had 2 vaginal stitch losses, they went on and had successful pregnancies with the abdominal stitch. So additional information, this is a really good procedure. The Arab pessary is around. We are doing research on the moment. FIGO do not say it should be recommended yet outside the context of research. It's a nice simple rubber ring to put around the cervix, and there's still ongoing research about that. I want to share with you about the training simulator that we've developed, which, the technique of putting in a stitch is obviously very variable, and it requires a certain amount of experience and skill, given the operating up a relatively tight area, which is challenging both technically and visually. So that we found that this training simulator is a really good way of improving sort of technique before people get sort of let loose on real patients and they can actually do their first procedures successfully. Now, sometimes we can't succeed with these prophylactic interventions, and therefore people go into labour. They may not have risk factors, they may come in, or they have risk factors and the interventions have failed. And getting the people to the right place for the right care is really important. Giving antenatal steroids and magnesium sulfate and getting the right people involved. This is the preparation aspects of our care. And it's really important to remember that we often can't prevent preterm birth, but we can improve outcomes. And sometimes, because infection is involved in these babies, it's not good to keep the baby in utero. The baby should be delivered, but in those circumstances, you want to optimize the start in life, and this is when these interventions make a big difference. So the corticosteroids we all know and love and been around for a long time. It's really important that they're given correctly, because if they're given too early, they're given to the wrong populations, they can cause harm. Here's a typical slide, old slide now, showing all the relative benefit of steroids across the board, and this is now established practice. But this study shows that if you give the steroids in the correct time, it makes a very big difference. So if you give them 24 to 47 hours before delivery, the babies do well. Even if you give them a few days later, they won't do so well. So if you give them more than 7 days before delivery, the outcomes are considerably worse. So I would encourage you to go and look at the evidence base on antenatal steroids, the FIGO recommendations. Jane Norman led this, very nicely describe who should get steroids, when they should be given, how they should be given, what should be given. And I think this is one area where we can definitely improve practice. There are differences between low and high income settings, and it's nicely elucidated in these recommendations. So I'm going to leave you with the ambition from the UK, which is to reduce preterm births from 8% to 6%. We've only got a few years to do this now, but I think we have the tools. I've spoken to you about high-risk management, seeing women with risk factors, but there's much more to preterm birth. There are huge areas of practice that can change whether people go into preterm birth. They range from oncology, NETs management, cesarean sections and labour, management around domestic violence, all sorts of other areas. And I think if we all did our little bit, I think we can gradually make a difference and reduce the rates of preterm birth. And also clinician behaviour around when to do cesarean sections, IVF practice, putting in multiple eggs. All these things have quite an impact around the world and will continue to do so as infertility practice escalates. So I think we have to look at this critically and not forget what an impact it is. And in the UK now, we tend to encourage one embryo to be replaced simply because the outcomes are better. And although you may have to do repeated infertility treatments, you end up not causing a huge problem. And it is very rare for us to see triplets now, which do have a considerable morbidity. I just want to thank all the fantastic people I work with who work in my preterm birth surveillance clinic. This is the team that have developed the app and helped with the many clinical trials we do to look at interventions. This is a really exciting area. In the last decade or two, there have been huge advances in our ability to predict problems. Our understanding of why people go into preterm birth has escalated incredibly, and the interventions to make a difference are there. I think we've reached the point where we just have to implement them. We have to educate and improve our knowledge about what to do, when to do it. And I think that's where we are. And with that, I think we can make a big difference in the coming years. And that's why I think it's so nice to be able to talk to you about our experience. And I hope you can take on some of the things I've said and introduce them into your practice. Thank you very much.
Good evening, friends, and thank you all the panelists. Andy, as usual, fantastic presentations. And this is an excellent presentation we had on this preterm, all the 3 Ps. I think you nicely put a slogan on the 3 Ps to prevent preterm. So, and they care the preterm babies. Any questions or anyone has have, please.
Can I ask whether the cervical pessaries is easily available and what is the cost?
I'm so sorry, I didn't quite hear the beginning of the question.
Varsha, that can be answered by Professor Ballard, because whether it is available in India, you want to know.
Yes.
But they are using. Dr. Ballard, do you have any idea whether these pessaries are available in India?
Still not it is available in India.
Dr. Jitendra Malhotra has used them, but he has little data.
Yeah, only thing is, it's most of the time, some of the people are getting it from the Europe and US. And I think one of the colleague from our US, Dr. the Mac from the Delaware, he had brought and shown to us in our about 7 years back when we are doing a clindamycin trial for prevention of preterm birth. Dr. Sheenan, I have one question. If Lisa, if it is permitted.
Lisa is here to answer on his behalf.
Yeah, I know.
Can I say something?
Yeah, please.
Yeah, the Arabian pessary is available in India through Amazon, and it costs about 6,000 rupees.
Okay, thank you.
Because it has been used in Bangalore. I haven't used it, but some of my colleagues have used it, and they have found it very effective.
So just to add to that as well, absolutely. So I think progesterone, Arabian pessaries and stitches have all been used in different countries and shown to be effective in studies. But I think the issue that we have is we don't really know which is most efficacious and in which, our particular group's going to benefit more from one type of treatment. So they have actually just done a big multi-centre study in the UK, which randomised women that had a short cervix less than 25 millimetres to either Arabian pessary, progesterone or stitch. But we're just waiting for the results of that trial at the moment. So it should be out very soon. It's finished data collection and hopefully the results will be imminent.
Actually, France trial was the one which brought up this pessary, but still in US, they are not routinely recommending because their randomized control trial has not been done in a big way. So they are also waiting for the results of this trial. But a small trial did not give them the better edge over the standard practices. That's why still they are not recommending. I don't know when that trial results will be out. We have to see. Wait.
Okay. Thank you, Dr. Ballard. And Lisa, let us go for the second talk of Dr. Anna. And whatever questions are there, I think Ame and Sujata, they will answer all the questions in their panel discussion. So Yogendra, please show the slide of CV slide of Dr. Anna and Dr. Jyotika. Yeah, Jyoti, please.
Yes, ma'am. Yeah, so that after that fantastic talk by Professor Shannon, we move on to our second talk by Professor Anna David. And for this, we have our chairperson, Dr. Lisa, and Dr. Jyotika Desai. Dr. Jyotika ma'am is a past president of Bangalore Society of Obs and Gynae. And over to Dr. Lisa to introduce our speaker, and then Dr. Jyotika can conclude the session.
So, thank you. So Professor David is going to give the next talk. Again, it's pre-recorded. She's actually Professor of Obstetrics and Fetal Medicine at UCL in London. She's also the Director of the Institute for Women's Health there as well. She's also an honorary professor in Leuven, and she does quite a lot of work with fetal surgery as well, which sort of ties into her next talk too. But she also runs a big preterm birth clinic in UCL as well, which is very similar to the one that we run at St Thomas's. So thank you. So I will share her talk with you in a second when I can share the screen. Great. Just find it. Great. So hopefully you can see this at the beginning.
Thank you very much for inviting me to talk to you about preterm premature rupture of membranes. My name is Anna David. I'm a consultant in obstetrics and maternal fetal medicine at University College London, and I run a preterm birth clinic at UCLH. So I have no conflicts of interest to declare. And what I'm going to talk about today is some learning objectives to appreciate the biology of fetal membranes, to learn why fetal membranes might rupture and why they don't heal, to understand the best management for women with preterm rupture membranes, or PPROM, and to remember the mother because her safety is really the priority. So a typical patient might be this patient of mine who I saw a few years ago. She was a 35-year-old lady, Afro-Caribbean. She was in her second pregnancy. In her first pregnancy, she'd had a first trimester miscarriage. And in her second pregnancy, she had a 26-week preterm premature rupture membranes, or PPROM. And she wanted to know, why did she PPROM? And we talked through what was the best management. So PPROM complicates up to around 3% of all pregnancies and is associated with 30 to 40% of preterm births. And it can result in significant neonatal morbidity and mortality, including preterm birth, sepsis, cord prolapse, pulmonary hypoplasia, but also for the mother, chorioamnionitis and placental abruption. So we need to think not only about the fetus, but also about the mother when we think about PPROM. The median latency after PPROM is 7 days. In other words, the median time from when women rupture the membranes to when they actually deliver is around about 7 days. But it tends to shorten as the gestational age after PPROM goes up. What's the etiology of preterm birth? Well, it's very multifactorial, as you will have heard from the previous speaker. And there's a variety of factors that can interplay to cause preterm birth. For PPROM, probably the most important ones are infection, cervical weakness and trauma, placental problems and vaginal bleeding, and excessive amniotic fluid. And that's because in PPROM, there's activation of the decidua and the fetal membranes, which causes prostaglandin release and matrix metalloproteinases to be increased, which break down collagen. And there's uterine contractions, cervical ripening, and all of these things end up in causing preterm birth. Now, at term, there's a programmed cell fetal membrane rupture, which we can see here. At the bottom, you can see the cervix, and just above it is the ZAM, or the zone of altered morphology, which is an area of the fetal membrane which is prone to weakening. Further away is the zone of intact morphology, or the ZIM. And just before labour, you get expression of highly polymorphic HLA A, B, and C determinants of fetal origin, which are exposed to the ZAM and to the maternal immune system, which undergoes a sort of graft rejection-like program. you get activation of cytotoxic decidual natural killer cells and just a decline in macrophages that are immunotolerant. And this all causes rupture of the membranes. And in pre-prom, this can occur preterm. So in particular, inflammation and infection can cause increase in TNF production, and decidual bleeding causes increase in thrombin. This activates choriodeciduous cells to produce GM-CSF, which activates monocytes, macrophages, causes release of proteases, for example, matrix metalloproteinases, and that causes amniotic membrane weakening. But it's also worth remembering that, in fact, just repetitively straining the membranes can cause all of these activations to occur. And this is something that we investigated back in 2014. And this was a group that I've been working ever since then, exploring the fetal membrane biology with Tina Chowdhury, who's a bioengineer, and with Kiara Curran and her husband here and family, who sadly lost a baby after PPROM. And she's developed a charity called Little Heartbeats, which is dedicated to women who rupture membranes early preterm. And this is the scientific group that I've been working with. So what we did was we took samples of amniotic membrane that term and we subjected them to cyclic tensile strain. So 2% once every 10 minutes for 24 hours in a Bose machine. So this allows you to repetitively strain the membrane and to have a look at what happens after you do that. And what we found was that there was an increase in prostaglandin release in those samples of membrane that were near the cervix or the placenta when we strained them. There was an increase in collagen, there was reduced elastin in strain, and all of these things go to make the membrane weaker. Now we know that if we cause uterine stretch, for example, polyhydramnios around the fetus, we do get PPROM. And we know that in, for example, multiple pregnancies, twins and triplets, 50% of twins are born preterm and triplets, 90% are born preterm. And is this because of uterine stretch, or is it because the cervix is weak? Well, a very elegant experiment was done in non-human primates where they implanted amniotic cavity balloons in primate pregnancies, and they expanded them. And as you can see, with time and with expansion and the amount of volume of the expanded balloon in the uterus,
I think Dr. Lisa, you'll have to unmute yourself. Dr. Lisa? Yeah, thank you. Thank you.
Diagnostic procedures such as amnio produced here or fetal blood transfusion can result in PPROM. And fetal blood transfusion has a rate of about 0.3% PPROM. In addition, prenatal therapy, so open fetal surgery, fetoscopic fetal surgery, also makes a hole in the membranes. And PPROM complicates 30% of fetoscopic cases, which compromises the outcome of treated babies, reducing the clinical effectiveness of fetal surgery. There are a number of interventions that occur in fetal surgery, for example, fetal surgery to treat spina bifida, and also fetal surgery to treat twin-to-twin transfusion syndrome using a laser as illustrated here. And you can see the video if you want to look here. So,
hello, can you still hear me? It just seems to have frozen. Let me just.
Oh, you're not able to hear anything.
Yeah, hold on.
Lost connection or what?
Yes, possibly. Let me just. I can still hear you, but let me let me try again.
Lisa, you can stop the video. Probably it will be clear.
Yeah, let me just stop the video and then try again. Oh, that is bizarre. Let's just. It's 7 minutes 17. let's stop it and start again. Might be the easiest thing. Hold on. I'm just going to reload it from the beginning. Just bear with me for a second and I'll try and...
Are you able to access it, Lisa?
Yeah, I'm just restarting it. Sorry, it just takes a second, but hopefully...
Take your time. Don't be stressed.
Yeah, I think it's... Hold on. I'm just getting back to the point where we left off, which was about 17. Yeah, right. Okay.
Yeah.
Let me... If in doubt, restart it, and that seems to make it work again. Let's share the screen.
So the fetal membranes, it was always thought they used to heal up, but in fact we've demonstrated that the membrane doesn't heal up. This is a fetal membrane that was taken to a 28-year-old patient who had laser fetoscopic surgery for treatment of stage 1 twin-to-twin transfusion syndrome at 19 plus 3 weeks. And she had a cesarean section at 29 plus 4 weeks following PPOM and preterm labour. So 10 weeks later, this hole was still there. Now sometimes the hole appears to heal up, and we think possibly that's because the chorion slides away from the amnion, and in fact the holes don't meet up. But it is true that actually if you look, you will find the hole in the fetoscopic surgery in the membrane many weeks following the actual surgery procedure. And if you have a look with the electron microscope, this is the amnion and the chorion split apart. You can see here very fine areas of trauma at the edge of the defect. When we look at the human amniotic membrane, it's not just made up of cells, it also has elastin and collagen, as you can see here. And the amnion epithelial layer is really very thin at the top, and it's made of cuboidal amniotic epithelial cells as a compact layer, a fibroblast layer, an intermediate spongy layer, and this is the chorionic membrane side. And you can see here, this is the amniotic epithelial cells, and underneath is the collagen. And if you take a sample of a defect, for example, after fetoscopy, and you have a look at it under the microscope, you can see that at the very edge of the wound, the cells are dead. And what we did was we had a look, and we did second harmonic imaging to see where is the elastin and collagen lining up. And if you take a control sample away from a hole in the membrane, you can see that there's very little lining up of the collagen. But when it's near the wound edge, the collagen actually does line up, suggesting that the cells are trying to make some kind of healing process. We particularly investigated a protein called connexin 43, which is a gap junction protein. And we know that overexpression of connexin 43 in skin wounds, which fail to heal, is a problem. If you downregulate it, you knock down the connexin 43, you can encourage skin wounds to heal up. So we were quite interested to find out, why is it that the amniotic membrane isn't healing up? And we found in those membranes that were wounded near the wound edge, we had overexpression of connexin 43, overexpression of COX-2 and prostaglandin production, and reduction in collagen gene expression. So we decided to test this out in an artificial fetal membrane trauma model, in which we took fetal membrane, we made a hole in it, we exposed it to amniotic fluid underneath, and then examined it over 24 hours. And what we found is, when we had a look at 24 hours and 168 hours, what happens is that the cells migrate down over the edge of the wound, and you get connexin 43 expression. We also found very high expression in the wound edge, as you can see here, in those wounds that were tested out at 24 hours and 168 hours after being wounded, whereas in the control, there was no difference. So what happens is when you make a hole in the amniotic membrane, or when a hole occurs, there's an attempt by the cells to produce collagen, and there is some sort of purse string contraction that occurs, but it does depend on the size of the defect. If the defect is quite large, such as with the fetoscope, then it doesn't heal up completely. But if the defect is quite small, for example, an amniotic, was tend to heal up. But we don't really know how big the defects are that occur in women who want to go PPROM, for example, due to infection or bleeding. It could be that they're very large, and therefore that is why they're not healing up. And what we've since gone on to show is if we knock down this connexin 43 using antisense, we can actually improve the healing of the amniotic membrane defects. So back to our patient. Why did she PPROM, and what is the best management? Well, in this particular case, she actually had heavy vaginal bleeding the first part of pregnancy and probably PPROM'd in relationship to that. Much of the management is really taken from NICE, a preterm labour and birth guideline, and the Green Top guideline published by the RCOG in 2019, which specifically for women who present with preterm pre-labour rupture of the membranes from 24 weeks. It's important to make the correct diagnosis. So very important to take a detailed history to ask about vaginal discharge, perhaps the fluid that she had was actually urine, was she incontinent of urine? Has she recently had sexual intercourse? I mean, it may be that the semen is actually leaking out. So perform a speculum to look for pooling of liquor. And if pooling is seen, then the diagnosis is almost certainly going to be PPROM. But be very careful about bulging membranes, because sometimes what can happen, you look at the cervix and you think there's fluid there, and actually it's fluid coming through the membranes, or what's called a transudate. If you don't see pooling of fluid, then the RCOG guidelines suggest that you try a test, for example, insulin-like growth factor binding protein 1 test, or placental albumin globulin 1 test of vaginal fluid. These are all tests that basically allow you to pick up proteins that should normally be in the amniotic fluid and not in the vaginal fluid. But they're not absolutely guaranteed, and they do have false positives, for example, if recently they've had sexual intercourse or if they've had vaginal bleeding. So if you're not absolutely certain, then don't make the diagnosis. Another way to do that is to actually have a look by ultrasound. It may be useful if there is reduced amniotic fluid index, but a normal liquor volume does not exclude PPROM. And therefore, it's probably quite important to reevaluate and potentially say, well, I'm not certain that there is PPROM here, but I'm going to admit you to hospital, I'm going to reevaluate, have another scan in 24 hours. It's also important, if you think that they have got PPROM, is to do an ultrasound to check particularly the fetal lie, because if they're ruptured the membranes preterm, the baby may actually be lying perhaps transverse or perhaps breech. It's important to do an estimated fetal weight to work out how big the baby is. I mean, for example, to talk to the etiology consultants and check to see if they have a cot. And the first thing they'll ask you is, what gestational age is she? And the second thing they'll ask you is, what's the fetal weight? Also worth having a look at the fetal Dopplers. For example, has the fetus got normal umbilical artery Dopplers, which may be helpful in identifying if there is any placental insufficiency, which might have caused the PPROM to occur. Tests for infection are very important as well, so it's worth doing a low vaginal perineal swab for group B streptococcus, and that's because if there is group B streptococcus, then there is some evidence to suggest that these women should not be allowed to have expectant management beyond 34 weeks of gestation. If they have group B strep, we are going to give them antibiotics, which will probably get rid of it, but it's important that they don't have expectant management beyond that time. Do a high vaginal swab also to check for any other infection. Send off a bloodstream urine to check for urinary tract infection, because that potentially may be a cause. And consider other causes of infection, for example, viruses. Has she developed cytomegalovirus? Has she developed COVID, for example? Rule out other causes of infection and think outside the box. Other viruses may have picked up, and there may be some other tropical diseases that she might have been exposed to, which might have caused her to rupture the membranes. Take maternal blood for a C-reactive protein to check for infection. Blood cell count also to check to see whether she has any evidence of infection. It's worth doing primary sonography to check for a raised fetal heart rate or fetal tachycardia, because all of these three signs, if they are abnormal, will go on to make you think that she has an infection, and possibly that delivery is going to be the best thing for her and the baby. What about treating PPROM with antibiotics? Well, the Oracle 1 study, which was published quite a few years ago by the team led by Sarah Kenyon, really showed us what to do in this situation. This is the Cochrane systematic review, which looks at antibiotics, and it found that antibiotic use was associated with a reduction in chorioamnionitis, a reduction in the number of babies born within 48 hours and 7 days, a reduction in neonatal infection, use of surfactant, oxygen therapy, and abnormal cerebral ultrasound, but there is no significant reduction in perinatal mortality or an effect on the health of the children at 7 years of age. Commonly, we use erythromycin, 250 milligrams for 10 days, and then we stop. Azithromycin is an alternative, but avoid amoxicillin, as it's known to increase the risk of necrotizing enterocolitis in the neonate. It's important to transfer the woman to the best place for birth. So, for example, if you're in a unit where you are unable to offer a cot for the fetus, if it's possible to transfer the mum before she goes into labour, then that's the best thing to do. What about trocholysis, stopping labour contractions if she has them in PPROM? Well, it is associated with an average 73 hours longer latency of delivery and fewer births within 48 hours. But it is also associated with an increased risk of a 5-minute APGAR score that's less than 7, and an increased risk for ventilatory support in the neonate. And for women who have PPROM less than 34 weeks, trocholysis increases the risk of chorioamnionitis. So it's worth thinking about whether it's beneficial or not. It may be beneficial short term while you get the mum to a unit where they can look after the fetus. Plan the labour and the birth. It's important to think in preterm prom whether the fetus is actually in a malpresentation. If the fetus is breech, it may be more sensible to do a caesarean section. If the fetus is transverse, for example, you may have a higher risk of delivery complications such as poor prolapse, and so you may need to think about caesarean section rather than allowing her to labour. Give antenatal corticosteroids to mature the fetal lungs. In PPROM, steroids reduce the risks of respiratory distress syndrome and interventricular hemorrhage in the neonate, and therefore of benefit. Magnesium sulfate in labour to prevent cerebral palsy. There's not much data on PPROM itself, but it does improve the outcome for women who are delivering preterm, and it's anti-inflammatory, it's vasodilatory, increases the oxygen availability, and appears to reduce the effect of fits in the neonate. So it's definitely worth giving once they are actually in labour. What about the long-term management of PPROM? Should we be offering home monitoring to women? Many women who have vaginal bleeding don't necessarily go into labour immediately, but the decision to offer outpatient care to women with PPROM following a period of inpatient care should be made on an individual basis. Remember, the average latency is around about 7 days, so you probably should admit them to hospital for at least 7 to 10 days before considering sending them home. Once you do get them home, we tend to see them regularly, every week to 2 weeks, and that's because it's highly stressful for the mum and the dad. We monitor fetal growth fortnightly, we have a look at fetal well-being via Doppler, and we also offer psychological support. Other things that have been tried, amnioinfusion has no benefit and more research is needed. And the rationale behind amnioinfusion was to try to improve the neonatal outcome by replenishing fluid around the fetus so that they're able to prevent pulmonary hypoplasia. When you have reduced fluid around the fetus between around 16 and 24 weeks of gestation, lungs fail to develop because the fetus has to breathe the fluid in and out of the lungs. And so you can have a woman who ruptures their membranes very early and doesn't go into labour for many weeks, but then sadly the baby's lungs don't develop properly. So amnioinfusion has been tried, but so far there is no definitive benefit to this and potentially may be harmful to the mum and the fetus. When to deliver? So for women with root B strep colonization, delivery by 34 weeks is preferable because they may have a higher rate of infection. But in PPROM, with no contraindications to continuing the pregnancy, expectant management until 37 weeks with careful monitoring has better outcomes for mother and baby. Because early delivery is associated with increased respiratory distress syndrome, increased rate of cesarean section, a higher rate of neonatal death, and increased need for ventilation. But it's important to individualise care because many of these studies were actually conducted in late PPROM between 34 and 36 weeks. And so in women with PPROM less than 34 weeks, it's important to remember that these figures may not be relevant to them. And it may be sensible to actually deliver them earlier than 37 weeks. It's important, particularly in women who have very early PPROM, that maternal mobility is really, really important to monitor for. We may well want to wait as long as possible to gain fetal maturity, but it is at the cost of maternal safety. And this is a really nice recent study from the US that monitored 208 women with PPROM less than 24 weeks. And they compared 52% who chose expectant management with 48% who chose to have termination of pregnancy. Overall, there was a 2.8% rate of admission to intensive care unit with expectant management, with 0.9% rate of unplanned hysterectomy compared to none of those in the termination of pregnancy group, and a doubling, almost doubling the composite maternal mobility score in those women who had expectant management, 60.2% compared to 33% on termination of pregnancy. Among women who chose expectant management, 15.7% of them avoided mobility and had a neonate who survived discharge. So it's really important if women do decide to have expectant management that their care is optimised, that they're monitored closely, and if there are any signs of them developing infection, that they should have their delivery expedited, and that may mean having termination of pregnancy if that is allowable where they are living. So overall, this is the summary of what's recommended by the RCOG Green Drop Guideline, which is a really useful summary of all the evidence. To make the diagnosis by maternal history and sterile speculum examination. If you can't see any fluid, consider performing a test. Following diagnosis, give erythromycin, preferably for 10 days, or until the woman is in established labour. Women who have PPROM between 24 and 34 weeks of gestation should be offered steroids and consider them up to 36 weeks. Use clinical assessment, maternal blood test, CRP and white cell, and fetal heart rate to diagnose chorioamnionitis in women with PPROM. If you have women whose PPROM after 24 weeks, and they have no contraindications to continuing the pregnancy, they should be offered expectant management until 37 weeks, and discuss timing of birth individually if they have PPROM early. Women who have PPROM and established labour or having a planned preterm birth, IV magnesium sulfate should be offered. So I hope that you've learned something useful from this. We aimed to talk about the biology of fetal membranes, why fetal membranes rupture, why they don't heal, to understand the best management for women with PPROM, and to remember the mother. Her safety is the priority. So I'd just like to thank colleagues, the research team that I work with at Queen Mary University of London, UCL and KU Leuven, the funders who've supported us over the years, and to say thank you for your attention. If you'd like to have any further information, please don't hesitate to email me at a.david@ucl.ac.uk. Thank you.
Fantastic.
Yes, Jyotika, your comments? Yeah. Unmute.
Thank you, Dr. David. That was an excellent presentation. We were fascinated by the information on why amniotic membrane doesn't heal. That was really fascinating to see all the pictures and the beautiful videos. I would like to ask you, is Dr. David there?
No, Dr.
She's recorded.
Lisa is there.
Lisa is there. Okay. Then can you answer, Lisa? How often do you all use tocolytics if there is a PPROM?
Yeah, so I typically don't use them ever in pre-PROM just because of the risk of infection, because I think one of the etiologies that we know about obviously is infection, and it's a bit like a chicken and egg situation. We can't exactly be sure whether it's kind of subclinical infection which has caused the membranes to rupture, or the membranes rupture and then you get infection as a result. But I think, so certainly in the UK, they did a UCOS study over 18 months looking at women that had pre-PROM'd before 23 weeks. And actually they found a really significant maternal morbidity with that. So they had, I think about 1% of women actually died. That's not actually published yet, but that's from chorioamnionitis. So I think the last thing you want to do if there is an infection there is to, you know, essentially what you have to do is empty the uterus. So I know the Green Top guidelines as well say that we shouldn't really be giving tocolysis in pre-PROM.
Dr. Lisa, can I ask you, have you done an amnio infusion, and what is your experience about it?
Yeah, again, I haven't been in the kind of the research looking into kind of replenishing the amniotic fluid, if you like, and it's not something that we routinely do in clinical practice here. But I think again, it's the problem. It relates back to sealing of the membrane. So if they can't seal, essentially, even if you put the fluid back, potentially it's draining out again. But I mean, it's a very attractive thing to do, isn't it? Particularly for those very early ones where they're at really high risk for pulmonary hyperplasia, just to really facilitate that lung development. But certainly, I think it's right. It's a topic for more research, but it's not quite there yet.
Theoretically, it is, but practically may not be possible.
Yeah,
because
no, absolutely.
The LICA which has been put in, it disappears within 24 hours, so it doesn't really make any difference.
Yeah, I can see Dr. Ballard wants to make a point. Yes.
I just want to say that the amnio infusion worsens because it also may transmit the infection, number one. And
that's a really good point.
Secondly, it may move to the respiratory tract of the baby. That may be still worse, you know, that's why it may not be that. So I put a message also that it is more harmful. And I just wanted to know how is the practice. This amniotic seals they have developed and they put this, but my only question is how they will identify exactly the breakage of the amniotic membrane, what diagnostic tool they use. I mean, this is, I don't know, Lisa, because I'm not aware, but the literature says there are seals, amniotic seals.
You have something called fibrin glue and all. Are you all using it? Like
no, again, we don't routinely use that. And again, they're very attractive from a research perspective. But I think it's the same point that you raised earlier, which is a really good one, is the sense that because we don't really understand why the membranes have ruptured, potentially if there is subclinical infection there already, and then you seal it, you're potentially compounding a problem where you've got an infected intrauterine environment. And I think until we fully understand what's causing it. And one thing just observationally that I've just seen is that actually women who seem to have bleeding preceding membrane rupture seem to behave a little bit differently than the ones that don't. And, you know, what the role of the placenta is between those different groups, I don't think we quite understand yet, but it's certainly something we're looking into a little bit more as well. But I suspect because it's so multifactorial, it isn't one size fits all.
When the latency period is more than 7 days, there are cases where, you know, the pregnancy has gone up to 34 to even 37 weeks. Do you think the membranes have automatically sealed?
So that's a really, really good question. And I just, again, because a lot of my research is with these women and I'm on the wards with them every day, one thing that I'm not entirely convinced is that we're actually diagnosing it properly in the first place. Because I think there's certain subgroup of women who've been incorrectly diagnosed as pre-PROM. They've never had reduced Lycor volume. They have their twice weekly bloods, and then they get delivered iatrogenically at 37 weeks. Whereas the ones that have reduced Lycor, there is a higher incidence that they deliver within 7 days. So I think it's such heterogeneous data. And the other problem is, although we use these membrane rupture tests and they give very good sensitivity, specificity of whether the membranes have ruptured or not, you know, what's the endpoint? There's no gold standard to compare it to because there is no gold standard test for rupture of the membrane. So I think it's an area fraught with difficulties, but you raise some really good points.
Jyotika, one more point to add on what Lisa has told is almost 70 to 80% of them deliver after rupture of membrane within a week. Only very, very few, anecdotal cases which have gone beyond 3 weeks. Otherwise, 90 to 95% of them deliver within 3 weeks. I mean, this is one number one point. And secondly, we need to really look at those pregnancies, really they have gone, whether how the amniotic fluid has been monitored by ultrasound. Because if there is really a leak, there has to be a regression in the amniotic fluid index or single vertical pocket, whatever they are looking at. I mean, that's one point. And and secondly, the use of antibiotics. Actually, we did use one for predictions because our we did a pH study, Lisa, on that high vaginal pH, and is a predictor for preterm. And we wanted to see, but actually pH predicts, it is an indirect evidence of infection. So that predicts the good number. It's a 2/3, 66%. But we also tried randomized trial with the clindamycin. We used clindamycin, category B drug, but unfortunately we didn't use ultrasound for gestational age. It did not work in the community. So I just want to know the azithromycin and clindamycin between the two. We should really look at which really works, because azithromycin now everywhere they are recommending for prevention of infection, perinatal infection. Both it will prevent infection in the mother as well as the baby. So how is your experience on that?
Yeah, so we tend to use erythromycin as our first line, so the 10 days course. And it's really a membrane stabilizer. So I think it's sort of trying to, prevent the woman actually going into labor. When they've done studies on other antibiotics, and I don't specifically mean azithromycin, I mean things like, coamoxiclav and things like that, they've found that they don't improve outcome. And actually what we've found, I'm always a little bit cautious about treating with antibiotics other than the ones you've described, unless the woman has an overt infection, like a urine infection, because you can end up in a worse situation that you're sort of masking an infection, and then you end up with much worse both maternal and fetal outcomes, because we know that babies that are growing in an infected environment have a much higher incidence of cerebral palsy, they have a higher incidence of necrotizing enterocolitis, retinopathy of prematurity, and likewise the mothers, because they're young and healthy women, they're sort of compensating that you can't really see until suddenly they can't compensate. So I guess I don't mean it quite the same way. It's a bit like if you have an abscess, you can give antibiotics, but unless you drain it, it doesn't heal. And in a way, chorioamnionitis is a little bit the same, in the sense that unless you empty the womb, if there is an infection there, nothing's really going to treat it properly.
Yeah, actually, erythromycin and the other amoxiclav, they came from the NIH study quite early. But, unfortunately in India, we do not have still injectable erythromycin, how it is available in Europe and USA. So whether do you recommend injectable erythromycin or oral? We
just give it orally. We give 4 times a day oral. And then if we have to deliver the woman preterm, then we'll give benzoyl penicillin in labour to cover group B strep for actually when we're delivering.
Jyotika, there is one question in the chat box.
Yeah, 1 minute, Bella, 1 minute. Yeah. Amoxicillin and clavulanate are not advised, especially the amoxicillin in combination with clavulanic acid. Amoxicillin by itself is fine, but with clavulanic acid, it can cause necrotizing enterocolitis in the baby one after birth. So it's definitely contraindicated.
Absolutely, and that was the Oracle study. So I completely agree. We are cautious about giving them.
And not only that, even late any maternal infection also, we should not give amoxiclavulanic acid because it gets transferred.
It is the clavulanic acid which is at fault, not just the amoxicillin. There is a question. Dr. Kishore wanted to ask. Dr. Kishore, if you can unmute yourself, you can ask the question.
I don't think so. He can unmute.
Yeah, we won't be able
I think he has sent it in the chat box. I'll read it.
Ma'am, the question actually is asked about that test, the arborization test, which is a simple test, whether it can be done. So if Dr. Lisa, if you can take that quickly.
Yes, so you mean for testing for rupture of membranes. So the only ones that really are advocated in... Oh, sorry, go on.
we don't have PAM1 or we don't have insulin-like growth factor, so when we don't have these two, then how do we find out if there's a leak? Whatever we see visually, yes. But if we don't see visually, how do we manage?
To be honest, I think I have the same problem even with the test, to be honest. I think it comes down to good clinical skills. Yes. It's taking the history, making sure they don't have urinary incontinence or, something else that might explain why their underwear's soaked. Looking and also just making them lie down for an hour before you do the speculum just to check whether they've got that pooling. And to be honest, if it's a good history, doing a bedside ultrasound and seeing there's reduced LICOR, it all adds up together to create quite a compelling case. But I think we are really relying on clinical acumen, even in the era of these tests. I think it's really important to listen to the woman and do a proper examination.
Magnesium.
Because LICOR has sodium chloride, if we do an arborization or a Fern test and we detect sodium chloride on the slide, it's a gross way of finding out, crude way of finding out that yes, there has been some leak. That is what the question was about. And the other question is there a term called high leak? We have come across patients.
Yeah, I think the Fern test, from the studies, we don't use it in clinical practice anymore. I think the evidence is a little bit uncertain to the efficacy. And yeah, we talk about hindwater leaks, things like that. I'm always a little bit skeptical of how useful these terms are. And my own personal view is that I think we're misdiagnosing a lot of women to have ruptured their membranes preterm when they probably haven't actually ruptured. And they're the cohort that do very well, unsurprisingly. But that's just my personal experience of it.
Right. Thank you so much. Thank you, Dr.
One more question.
Yes.
Just a minute.
Welcome.
There is a question by Dr. Kamal Patel. She has asked we in India use magnesium sulfate for neuroprotection from 28 to 32 weeks. But in UK, do you use earlier to that? That's a question. When onwards we should use?
So that's a really good question. So I think part of the issue with magnesium sulfate is that it was never evaluated in its own right. So it's almost a bizarre story in the sense that we've introduced something into practice without it really ever being evaluated for that indication. So the reason we use it is because in the women with severe preeclampsia, they did a subgroup analysis of the women receiving magnesium sulfate and found that the babies that had it obviously had a much better neurological outcome. So it was never really evaluated to work out what the optimal timing is, what the optimal dosing was. And as a result, we just give it like we do for women with eclampsia or severe preeclampsia that we think is going to fulminate. But from my perspective, if you look at the NICE guidelines here, we give it up to 30 weeks or 29 plus 6 days. But I think if you've got a viable baby, if you think the baby is going to survive, even if they're 23 plus 6, I would give them magnesium at that point, because you're trying to reduce the morbidity. And actually, it's those babies that probably need it more, because obviously the curves of morbidity change depending on gestation. So the minute, if you're treating that baby as a viable baby, you've got the neonatologist there, they're ready to resuscitate, I would give magnesium sulfate at that point.
Another thing, Jyotika's answer, instead of arborization, I feel that pH of the vagina probably will be better than, because vaginal pH is normally acidic. When there is a leak, amniotic fluid, which is an alkaline, so it will be above 7. So that's a much simpler than looking at.
What if she has bacterial vaginosis?
That's what I'm telling. Even there, it won't go beyond 7. Even if there is a BV, it doesn't go beyond 7, because we have seen that it is maximum 5 to 5.5 or 6, but it never goes alkaline, because LICOR is an alkaline. Probably that's maybe a simpler. I have not been using that. Let me tell you.
I think the other issue as well is,
there was a study, but I don't know. And I don't know the results, but I just remember that they checked the fluid in the vagina for beta HCG. And when it was positive, they found that there was a leak. So scope for further research.
Yeah, I think so. And I think the other issue is that the problem is I guess it depends a little bit of when you catch them in their journey of membrane rupture, doesn't it? Because if they've just ruptured and the vagina is full of fluid, then that's going to affect your results of all those kind of tests as well. Whereas if they give a history where they ruptured 3 days ago and it's just dribbling out a little bit, it's difficult to tell.
Just one last question. If she had a P-prom in the first pregnancy for whatever reason, is there a recommendation for giving progesterone in the subsequent pregnancy? Because there have been studies which say that it has reduced the recurrence of P-prom by 30%.
Yeah, it's a good question. I think certainly if they've delivered preterm as a result of the pre-prom, yes, we would offer it just as per we have Green Top and NICE guidelines, which would say a woman with a previous history, we would offer progesterone from the first trimester. But actually in our clinic, we do talk to them about progesterone, but we tend to monitor them a little with ultrasound surveillance. And we treat all of the groups similarly, if you like. So whether they've just had a spontaneous preterm birth without preceding membrane rupture or they've had a pre-prom, we would monitor with cervical length, put a stitch in if it's short, but we would offer them progesterone in the first trimester, certainly, if they wanted to pursue that.
Thank you.
Dr. Lisa, do you believe in high leak and low leak?
Yeah, really interesting. I'm not convinced, but I'm sure other people will be able to give you a very compelling argument why they believe it. I think none of us really know is the answer. And I guess actually just reflecting on Prof. David's talk there, you could easily see how, depending on where you're puncturing the membranes at an invasive procedure, you can see why it may occur in different places. But I don't know. I don't think we know enough about it yet. I think the more you read about preterm birth and pre-prom, you realise how many questions there are that are unknown. And I think the fundamental problem in treating it is that because we don't really understand what the cause is, it's very, very difficult to target your therapy. And we have lots of things that we know work, but we don't even really know why they work. Like, you take a stitch, we're keeping the cervix closed, but I also wonder whether when we look at some of these studies, we're looking at the right endpoints too. We always look at prolongation of the pregnancy as the ultimate nadir and, in effectiveness. But actually, maybe the longer term neurodevelopmental outcomes are the most important factors. We just don't know.
So thank you. Just a minute, please. Thank you so much, Lisa. Please convey our gratitude to Professor Andrew and Professor Anna. Please let us start with our panel discussion. Lisa is there as an expert and Srividya is also there. So the remaining questions they will answer in the panel discussion. Both the moderators are also patiently waiting for the panel to get started. So I hand over to Jyoti to start with the panel and we will take each and every question. Please, Sujata, Ame, please note down all the questions and try to answer during your panel discussion. And Lisa and Sri are there to give their expert comments throughout the whole panel discussion. Yeah, please, Jyoti, go ahead.
So that is the beauty of this. Actually, we share our knowledge and we listen to what RCOG people are saying. So now again, we have a hot panel discussion here. And for that, we have I invite our national coordinator, Dr. Sushma Verma, to please do the needful, to please invite our panelists and the moderators.
We are so happy with the team Indo International Web Series with the interaction going on. Our audience is so alert, attentive, and they are interacting. That is the sole purpose behind organizing these webinars. So we all are really feeling happy and satisfied. So please keep interacting in the chat box. Yes, Sushma.
After this wonderful and elaborate lectures on the prediction and prevention of preterm labor and its management and preterm PROM, I would like to invite Dr. M.C. Purande sir and Dr. Sujata Dalvi ma'am to moderate the case-based panel discussion. Welcome, sir and ma'am. Dr. M.A. sir, he is a consultant obs and gynae at Purandre Hospital, Mumbai, and he is second vice president of AMOGS 2022 and 24. And Dr. Sujata Dalvi ma'am, she is the consultant obstetrician and gynecologist at Mumbai and secretary of AMOGS, Association of Maharashtra Obs and Gynae Society. And then the panel is not complete without the presence of esteemed national faculties as the panelists from all parts of India. I would like to invite Dr. Dolly Mehra ma'am. She is consultant Obs and Gynae at Mehra Hospital, Ratlam, and she is past president of Ratlam Obs and Gynae Society and joint secretary of AMPOGS 2019 until date. And then I would like to invite Dr. Vidya Chaudhary ma'am. She is a professor and HOD of GMC Medical College, Jalum, UP. And Dr. Sarita Agarwal ma'am. It's my proud privilege to call Dr. Sarita Agarwal ma'am for panel discussion because she is from Raipur and she is our beloved teacher and she is professor and HOD of Department of Obs and Gynae and Dean Research at AIIMS Raipur. And she is the past Vice President of FOXI, ICOG Governing Council member, ICOG Academic Council member, and past Chairperson of HIV Committee. And then I would like to invite Dr. Shaila Jamal ma'am. She is Associate Professor of RMRI Bareilly, and she is Founder President of Society of Menstrual Disorder and Hygiene Management Committee. Welcome you all.
Sujata, the floor is all yours. Yeah,
no problem. Yeah, Ameya, I think Ameya will start. He will share the screen.
I hope you can see my screen and I am audible.
Yeah, please make it slideshow, Amey.
So first of all, thank you, Dr. Lakshmi Srikhande, for inviting us to be moderating this very important panel on preterm labor. On behalf of Dr. Sujata Dalvi, I extend a welcome to both our foreign guests as well as to our Indian experts. And we hope that this panel will not end soon, just like in preterm delivery, the pregnancy ends way before time, because you know that every baby is worth the wait. And whenever we are faced with a preterm birth, the sea is never smooth. But I have, and I'm happy to have these panelists who are many a skillful sailor in the journey of pregnancy. Why are we discussing preterm labor? That is because of the magnitude of the problem. Prematurity was, is, and perhaps will be the single biggest cause for neonatal morbidity and mortality, as it accounts for 2/3 of neonatal deaths. In fact, in India, preterm delivery accounts for about close to 20% of pregnancies, which is a pretty large number. And therefore, as obstetricians, it is our responsibility and our sincere efforts should be aimed to predict, to prevent, and manage preterm delivery. This is the 2013 WHO fact sheet, and you see that these are not COVID numbers, but these are preterm delivery numbers, and India is way high as compared to both the West and to even the Southeast Asian countries. Why is it so? Because there are two key factors. One is population density and two is GDP. The more congested the population, the higher the risk for preterm labor, and the poorer the population, also the greater risk. As you can see from these two world maps, which show that the poorer countries have got greater incidence, so also the more populated countries. We'll start by asking Dr. Shaila Jamal. Shaila, what is the exact terminology of preterm labor?
Yeah, Dr. Shaila.
Okay, I think we are not getting Shaila online, so maybe
we can ask Dr. Sarita.
Yeah, we can ask Dr. Sarita ma'am. Sarita ma'am, what is the exact definition of preterm labor?
Yeah, thank you, Dr. Ameya. This is like when we talk about the preterm birth, that is any birth before 37 weeks. Now, lower limit to take it is the age of limit of viability. So that's between 24 to 37 weeks is preterm. But we can further divide it into early preterm and the late preterm. So any preterm birth which is 34 plus 0 to 36 plus 6 days, it's actually a late preterm, and which is associated with less morbidities. But any birth before 34 weeks till 24 weeks, if you're taking the limit of viability at 24 weeks, but in our country, we take the limit of viability to be around 27 plus 6, that is 28 weeks. So that is associated with more morbidity. And then when you talk about the preterm, actually the diagnosis is by the history, that is presence of uterine contraction. If there is a regular uterine contraction occurring after 24 weeks of gestation, below 37 weeks, then it is preterm labor. So it is controversial whether to take the viability limit, which to be taken at the viability limit.
Okay, Dr. Srividya, I'd like to ask you, in the UK, what do you take as the cutoff of viability or salvageability? Do you think that it is a call by the obstetrician, or do you think it's the call by the neonatologist?
Thank you. That's a brilliant question. I think we have got recently BAPIM, which is the British Association of Perinatal Medicine, who have given us very clear direction. So we do start from 22 weeks onwards, but it is very clearly between 22 and 24 weeks. It is depending on individual circumstances and also based on the agreement between the physician, between the obstetrician, neonatologist, and the most importantly, the parents' wishes. So from 22 to 24 weeks, if it's a good, no infection and no IUGR or no other risk factors, and if the parents wish, then we do offer intervention. So from 24 weeks onwards, 24 to 34 weeks, we do offer the option of active intervention in majority of cases, except when there are serious congenital abnormalities.
Okay. Next question to Dr. Dolly Mehra. Ma'am, want to know, what do you mean really as threatened preterm labor? What does it mean clinically?
See, when the uterine contractions are increasing in intensity and frequency, and when they are associated with dilatation and effacement of cervix, then it is a definitive evidence of preterm labor. And if it is not associated with dilatation and effacement, then it is just preterm labor, or there may be no evidence of preterm labor. There are, when the patient is into preterm labor, there are only 10% chance that she delivers in 7 days' time after the establishment of preterm labor. But when there is a definite evidence of preterm labor, then she may deliver before 7 days as well.
Okay. So it's sort of a precursor stage or a stage in continuum as far as preterm labor is concerned. Yes. I'd like to ask Dr. Lisa, what do you think are the risk factors, and why has NICE called them modifiable and non-modifiable? And is it possible realistically to modify the risk factors?
Yeah, that's it. It's a really good question. But as your table nicely shows, obviously there are some risk factors like smoking that are modifiable. Obviously, it's very difficult for women to stop smoking in pregnancy, but I think just telling them the associations between preterm birth and smoking are quite helpful. Same with illicit drug use. I think the only thing we really actively screen for in our clinics is if women are complaining of discharge and it's obviously smelling a bit offensive, we will screen for and treat for bacterial vaginosis, because we know that actually treating bacterial vaginosis in the second trimester does reduce the risk of preterm birth. And likewise, if somebody's got a short cervix, we would recommend that they potentially abstain from work during that period as well. But how evidence-based that is, it's more kind of psychological support for the woman, I think, more than anything else. But certainly cigarette use, drug use, and screening for known infections where there are symptoms are modifier risk factors, I would say.
What about non-modifiable risk factors?
Well, I think for the non-modifiable risk factors, it's helpful to know that they've got a risk factor, because then you can deem them as being high risk and you can plug them into your preterm birth clinic. So now in the UK, following the preterm birth commissioning guidelines that's published in the European Journal of Obs and Gynae, all hospitals are supposed to have a preterm birth clinic where we're screening and managing women at high risk of preterm birth. So we would follow them up with regular cervical length screening, possibly in combination with fetal fibronectin. And then if we are seeing cervical changes, we can actually intervene in that group. So actually, even though we can't necessarily modify, we can increase how we're following them up to make sure we try and reduce the morbidity for both the mother and the child.
I think both the previous speakers have very clearly said, described to us that there are maternal causes which can cause preterm birth, fetal causes, there could be environmental causes. But what we need to understand that in 1/3 of patients, we really can't identify or pinpoint a cause. And that is the real challenge, because we will not be able to predict in these patients, prevent in these patients, and these are the ones that we need to reduce. So even though we have risk factors, we have factors on history which we can identify, still because of the multifactorial nature, there are times where we are not able to identify risk. The FIGO guidance on preterm labor and their working group very clearly said that the 4 important points which cause a higher rate of preterm birth in lower income countries than the higher income countries are the link factors. That is the lifestyle, infection, nutrition, and contraception. And I think these are important factors. As obstetricians, we must make every endeavor to ensure that we reduce the risk of preterm birth from these factors. So we'll ask Shaila now if she's there. Shaila, if you could quickly summarize for us, which could be the most important risk factors for preterm birth in clinical practice?
Thank you, sir, for putting up this question to me. Highest risk factors are having history of previous spontaneous preterm birth, cervical length shortening, if detected incidentally or you're monitoring, whatever is the reason. There are symptoms of infection associated with preterm labor, and presence of fetal fibronectin if we detect it, whether in clinical research setting or for our own interest. I think these are the 4 most important risk factors for predicting preterm labor.
Okay. So now,
can I add to this, Dr. Amaya? I think previous midterm losses are also a very important risk factors.
Okay, so madam, we have put that down as in fact the topmost. We said history of previous preterm birth. So
along with that, this preterm even less than 24 is midterm, midterm abortions.
Okay. So we'll now move on to the clinical case scenarios, and I hand over to Dr. Sujata Dalvi to take us further.
Thank you, Dr. Amaya. Can I have the next one? Yeah, this is a 30-year-old primie. She is being transferred to your tertiary care center with a preterm contractions at around 29 weeks of pregnancy. The pregnancy has been so far uneventful with normal blood pressure. On examination per abdomen, there are 2 contractions every 10 minutes, lasting for every 15 seconds and with a moderate intensity. I would like to ask Dr. Dolly, how would you go about clinically evaluating this patient? She has come in to your clinic, and how will you go about?
First of all, we are going to examine this patient, do her look at her vitals, her per abdominal examination. Then we do a speculum examination. We can also do her ultrasound to evaluate the amount of Leica and the Doppler studies to evaluate the blood flow to the fetus. And if she is dilating, then we go ahead with giving her the steroid prophylaxis. We also would consider magnesium sulfate for the neonatal protection, neuromuscular protection. And for all this effect to come, we may consider giving her the tocolysis so that the effect of steroid and magnesium sulfate does set in, and then we deliver this patient.
Anything specific on, one second, anything specific on per speculum examination for these patients?
We see for the dilatation, if we are able to see that there is, if the dilatation is more than 2 centimeter, and if the effacement is more than 80%, if there is any leakage We can also do fetal fibronectin in the cervicovaginal fluid if the membranes are intact. And at the same time, we can also consider transferring her to a tertiary care center with a neonatal.
No, she has already come to our tertiary care center. You know,
okay, fine. So we will consider tocolysis, steroid prophylaxis, and the magnesium sulfate for neuroprotection.
I want to ask Dr. Srividya, anything different that you people do it in the UK whenever a patient like this comes to you?
I think we do because we have got access to quantitative fetal fibronectin measurement. So we do take swab and measure that. And I think Lisa will be able to say, we have this quick app, which Professor Shannon explained in his.
Yeah,
and
sorry, Shri, I didn't mean to interrupt you, Karen.
I can take over, Lisa, because you
no, absolutely. Just as Shri said, the Quip app, although it's free to download from the App Store, and if you do have fibronectin available in your unit, you can use it in an acute setting as well as in a clinic for asymptomatic women. So if you have access to out of hours cervical length screening, you can do a transvaginal cervical length. But even if you don't, it still works with the symptoms the woman's having, her history, and the fibronectin result. And what it will do is give you a risk factor of the percentage chance that woman will deliver in the next week, 2 weeks, or 4 weeks. And that's quite helpful, because actually if the woman's risk of delivering is less than 10%, we potentially wouldn't even give the woman steroids, and that's, I think, really important, because a lot of the evidence coming out now is actually you want to time the steroids properly. We know they give benefit if you give them sort of between 24 hours and 7 days from when delivery occurs. But we're increasingly finding that if the woman doesn't deliver, and you need to give repeated doses, then that affects baby's neurodevelopment. But more than that, actually, if you give them and you don't deliver, the babies actually are smaller at delivery too. So really the key is to try and time the steroids so that the baby can get the most benefit with the minimal risk associated with them.
Yeah. One more thing, do you do high vaginal swab for any vaginal possibility of vaginal infection? Do you send it as a routine whenever any patients like this come?
We do, yes. But I think realistically, there's not much that we would actually treat on it, because I guess what we might see is group B strep, but we would give all women that are delivering preterm group B strep prophylaxis anyway in labour via antibiotics. Thrush, which you would treat, not that it's associated with preterm birth, but just for symptomatic relief for the woman. And bacterial vaginosis you may see, and we would potentially treat that.
Yeah, thank you. I want to ask Dr. Sarita, what is the role of sonography whenever a patient like this comes to you? Before you start off with any medicine, any therapy, what is the role of a sonography in these patients? We have already discussed fetal fibronectin. Clinical examination has already been done. What about the sonography? Does it have any role?
Yeah,
Dr.
sonography,
Sarita?
it is very much important. Basically, it is for the trans-abdominal scan to look for the fetal condition, the live presentation, and if there's any placental like abruption can be also there if there's a leaking, and if there's any fetal growth restrictions. So that is for the fetal condition as well as the amniotic fluid volume. And then in cases when the clinical examination is contraindicated, suppose the placenta is low lying and I can't do a digital examination to look for the dilatation of the cervix. In that case also, it can help to look the cervical dilatation, how much is the dilatation. Because if she's an established preterm labor, the prevention may be a bit difficult, and the counseling part is very, very important. So if you look for
she doesn't have a placenta previa, would you be able to judge cervical dilatation better with clinical examination, or would you still go in for a sonography?
Yeah, I'm a clinician. I will rather go for the my per vaginum examination, digital examination, to look for the dilatation of the cervix.
Fine.
But many times it happens, the external os may not be dilated, but you are getting in a funneling of the cervix. So the cervical length is very important. If the cervical length is less than 15 millimeter, on that case, it is important to predict that the labor can be, preterm birth is expected within next 48 hours. Similarly, the role of fibronectin is also there. If you have a facility for checking for the fetal fibronectin, if it is more than 50 nanogram per liter, then it is indicative. The level is more likely to be there in the next 48 hours. So these are the women who need a special care. And otherwise, if it is not the cervical dilatation is more than 15 millimeter and fetal fibronectin is negative, in that case, we can assure that fetal delivery is less likely, is less than 48 hours.
Fine. Dr. Shaila, any role of any electronic fetal monitoring, especially she is about 30 weeks, 32 weeks gestation. Dr. Shaila? Yeah, Dr. Shaila? Okay, Dr. Dolly, would you like to take it?
Yeah,
any role of any
Yes, to judge the fetal well-being, electronic fetal monitoring is very important, particularly when there is loss of variability. There can be infection or associated chorioamnionitis, and when there is deceleration, there can be cord compression because of the leaking of the liquor or the reduction in the liquor. So this is important, and electronic fetal monitoring should be done in all patients who are suspected of going into preterm labor.
Okay. I would like to ask Dr. Srividya, any role of tocolysis? Dr. Dolly immediately said that I would start off with tocolysis. So would you immediately start off with tocolysis, or would you take into consideration few factors and then only start off with tocolysis? If yes, which was that tocolysis of your choice?
Yeah, I think absolutely clinical assessment to make sure, it is make sure there is no other causes like abruption for the preterm labor, which is important, which has to be managed differently. If it is only a spontaneous preterm birth or a spontaneous rupture of membrane, because then we can give tocolytics for maybe 24 hours for just the steroids to work. But before that, we have to make sure there is no obvious and overt chorioamnionitis. So clinical examination like temperature, pulse, symptoms, blood pressure to make sure it's not sepsis and septic shock. And then CRP, white cell count. Of course, white cell count, we have to be aware that when you give steroids, it can go up, but after 3 days, it does come back. So if you have given steroids, you have to interpret the results appropriately. CRP is helpful, 75% sensitive for prediction of chorioamnionitis. So once we have ruled out everything, then you can give. And I think I can see here a slide which says nifedipine and atosiban. We go for nifedipine because it is easy to administer. So I think that's the commonest tocolytic we give very briefly, or sometimes when the patients have to come to our hospital from a smaller hospital, then it is just to cover the in utero transfer that period. So it's very limited, never more than 24 to 48 hours.
Fine. Dr. Sarita, if you were to give tocolysis, which one would you start off with?
Yeah, definitely. I'll start with the nifedipine. That is a drug of choice, and it works very well. We have used a lot nifedipine, and it really works very well. Of course, some of the women, they do experience hypotension and some dizziness with this use. But if the hydration is adequately maintained, that nifedipine really works. And if we are using the nifedipine, I think we are using only nifedipine.
Okay. Any time that you have used atosiban?
No, it's not available. It's
not available. Okay,
no,
we have used it in Bombay. I want to ask Dr. Lisa, how often do you use atosiban as a tocolysis in UK?
Yeah, so I mean, we have used it in the unit, but as Sri said, nifedipine is the first choice that we would essentially use in our unit.
I'd like to intervene, and I'd like to ask Dr. Dolly and Dr. Shaila if she's around. Dr. Dolly, as Indian physicians or obstetricians, our favorite seems to be isosuxapine. We are we find it's very convenient. We have large experience with it. It seems to be on the prescription base, the first line prescribed tocolytic. Do you agree with all this, or do you think that we are seeing a change?
No, I don't use isoxaprine. My drug of choice is nifedipine. And if it is preterm, I also use, along with nifedipine, magnesium sulfate that can be used, which provides dual function of neuroprotection as well as tocolysis.
Dr. Shaila?
I have stopped using isopropyl hydrochloride.
Dr. Dolly, I just want to intervene over here. You know, when we are using the nifedipine along with the magnesium sulfate, we have to be very much careful for the hypotension and also some of the cardiac toxicity. Combined toxicity of these two can lead to problem. So we actually avoid combining this thing.
No, ma'am, there are studies. There are studies that if you maintain the hydration, if the patient is hospitalized, if you are monitoring the patient, then that can be used.
So that is very true, but really it's to be very, very cautious. And about Dr. Amaya, you're talking about the isoxsuprine. You know, I am also very fond of using the isoxsuprine. I did not find any complication except in the cases where GDM or those with a sickle cell patient. So we are very careful using that. And in fact, sometimes we use this when the patient has a hypotension with the nifedipine and they're not able to tolerate. And then sometimes even we use the IV infusion of this duodenal and isoxsuprine and we find good result. But you know, now the latest guidelines, none of the guidelines recommend beta block, this isoxsuprine, therefore we stopped using.
Fine.
Because we are on the evidence-based medicine people nowadays, we can't use it. If the
Dr. Sarita, you have already started with isoxsuprine. Patients' contractions have reduced. Will you still continue giving tocolytic agents or will you stop it?
No. Tocolysis is not indicated after, say, around 48 to 72 hours of giving steroid and magnesium sulfate.
See, basically, this recommendation for the tocolysis only you get a catch-up time either to transfer the patient or you catch up time to give the steroid. So that is the only recommendation. Even if you continue beyond the contraction and stop or the steroid cover is there, it does not have any benefit in terms of the improved perinatal morbidity, mortality, or any resuscitative measure or Apgar score. So there's no role of continuing beyond that.
Fine. So you don't give tocolysis. Yeah, man.
The Etiology recent guideline says that there may be 3 possible strategies for using tocolytics. Like all of us have agreed that it's mainly acutely in preterm labor just to ensure that the steroids act and we transfer her to a facility with excellent NICU facilities. There may be a role in a few selected patients of maintenance therapy or in those patients who are at risk in prophylaxis, but these have to be judiciously selected. That is what the new ACOG or the American College guideline says. Over to you, Dr. Dar.
Yeah, I just want to ask Dr. Srividya, what about role of steroids? Which steroid do you use, betamethasone or dexamethasone, and how do you give it?
I think, you know, we ask our pharmacist which is available in our pharmacy. I don't know, for some reason, you know, there is a period we get only betamethasone and there is a period where we get only dexamethasone. So to be honest, it's what our senior pharmacist tells us to prescribe.
Fine. So either of it is okay, because in India, people are quite pro dexamethasone rather than betamethasone because betamethasone is not very easily available. So we stick to dexamethasone. So that's the reason I just asked you, what is the trend in UK, whether you use beta or dexa?
Yeah, I think the other thing is, you know, even though dexamethasone, the recommended dose is 6 milligram 12 hourly and 4 doses, in reality, we give dexamethasone like betamethasone, 12 milligram, 24 hours apart. Sometimes we even give 12 milligram, 12 hours apart if we feels like the delivery is imminent. And very rarely, you know, when women present with 7 or 8 centimeter, we have given the whole dose of 24 milligram to get the benefit out of it.
Yeah, so we also stick to the same thing. One more question about magnesium sulfate. When do you give magnesium sulfate? Patient is already on nifedipine, uterus is relaxed, but something or the other that you have to deliver the patient. So when would you give magnesium sulfate to this patient?
I think the ideal time is to be within 4 hours prior to birth, because then only the levels will be maintained to have the benefit on the fetus and the neonatal nervous system. You know, it is sometimes difficult because we can't predict, but we have a very low threshold to start magnesium sulfate, and then we stop or review if it looks like she's not going to deliver.
Fine. Okay. Thank you. Dr. Dolly, now this patient, somehow or the other, you've given her made all the efforts, but patient has gone into labor. How would you monitor this patient in a preterm labor and how would you deliver her?
See, it's very important to monitor the vitals of the laboring patient who is into the preterm labor. CTG is again an important issue. The obstetric decision whether to deliver normally or by cesarean depends on the obstetric causes. And moreover, episiotomy, whether to be given in these patients or not, it is to be given if the perineum is rigid or if there is some fetal compromise, then only episiotomy is given. In these cases, there should be delayed cord clamping. And if for certain reason that you are not able to do the delayed cord clamping, then milking of the cord can be considered. Presence of neonatologist is the most important thing.
Yeah, that's what I wanted to ask. What about the neonates?
Presence of neonatologists should be there. The neonatologist should be there before the delivery, and the baby should be taken care of by the neonatologist almost in all preterm labors.
Okay, so and what would you like to inform the neonatologist?
The gestational age has to be informed before she enters into the labor room.
Fine. Okay, fine. Over to Dr. Ameya for.
Yeah. So this baby was transferred.
I just want to add on to this. It is very important that we should inform our neonatologists pre-hand that they should be available to take care of the baby, and then these baby may require the immediate the support also. And then actually in all preterm, we also collect the high vaginal swab. So if the baby developed the infection, on that case, you have an option which antibiotic to be started on the baby to prevent the earlier neonatal infection.
Okay. So
and then the sudden delivery of the head is very, very important. This baby should be delivered by the senior person who know how to deliver the head, because sudden delivery of head can really be horrible for these premature babies.
Okay. I would like to add one thing. In these preterm babies, instrumental delivery should be avoided, particularly if it is less than 34 weeks gestation, because it leads to intraventricular
that we've already mentioned that. Yeah. Okay.
Just giving you the progress of this labor, the baby was transferred to NICU, was given surfactant and antibiotics. The CBC and CRP was high. The stay otherwise was uneventful and was discharged after 3 weeks with a weight of 2.4 kgs at discharge. And the mother has been breastfeeding for the last 2 years. Now, 3 years later, the same patient comes back to you. She wants to plan a second pregnancy. Dr. Lisa, what would be your advice to her? She's worried about preterm labor again.
Absolutely. So I think we would recommend seeing her in we would say to her that when you become pregnant, we'd recommend seeing you in the preterm clinic. I think if she did have any modifiable risk factors like smoking or anything like that, we can obviously address those pre-pregnancy. We would talk to her about progesterone, whether she wanted to take that from early in her next pregnancy, and then we'd recommend cervical length screening. We usually start that from 16 weeks and we do it every 2 weeks or so. From 18 weeks, we start using fibronectin. And then if her cervix was found to be short, less than 2 centimeters, we would offer her a cervical stitch. And that would usually be a McDonald stitch in the first instance. The only times that we tend to use Sherodica, we don't go in with a Sherodica as a first line, but we tend to find that women who've had LETS procedures or cone biopsies, sometimes the cervix is just very flush with the vagina and they need bladder affection to get the stitch in. But we don't go in with the aim of putting in a Sherodica. It's very much individualized.
Okay. Lisa, the NICE guidelines say that, and even the RCOG Green Top guidelines say that there seems to be a role of progesterone and it should be offered. So which would be the population of patients where you will offer it and where you'll start it?
Yeah, so we would offer it to women who've had a previous preterm birth, absolutely. And we would commence it right from the beginning of the pregnancy when we see them in the preterm clinic. And also, I think the NICE guidelines suggest that where women have an incidentally short cervix, for example, picked up at an anatomy scan or anything like that, then they would be offered progesterone as well. And some women just don't want to stitch as well. You know, sometimes you can find a short cervix less than 25 millimeters and they don't want to stitch. So, you know, that's another indication. But I think when we get the results of the trial comparing stitch versus Arabin pessary versus progesterone for women with a short cervix, I think that will be a really useful trial to have the results of.
So as you can see, this seems to be the consensus that if there is a prior preterm singleton birth or a twin pregnancy, you need to give her progesterone. If there is a short cervix with no prior preterm birth, still you need to give her progesterone. Just mere twins, no need for progesterone. Twins with prior preterm birth, yes, progesterone. And twins with a short cervix, you will give progesterone.
Can I interrupt there? I'm so sorry. Just this slide here where it says management for multiple pregnancies. So I completely agree. We would never give progesterone. But actually, when you look at the meta-analysis from the studies on cerclage, actually you do find that when you take your cutoff as slightly shorter, 1.5 centimeters, then those women do benefit for a stitch with a multiple pregnancy. So in our unit, we do offer them a stitch if their cervix is less than 1.5 centimeters, as opposed to the 2.5 centimeter cutoff.
Yeah. So Lisa, in this thing we've said that it's a normal cervical length, and that's why I've said that no cerclage, no progesterone. We move on to the second case now. She's a 33-year-old woman, gravida 2, para 1, living 1. She's 16 weeks. She has a history of previous spontaneous preterm birth. What should be offered to her and when? We'll start by asking Sarita ma'am.
Yeah, she is an elderly woman with 33 years, and as she had in a previous preterm loss, and at 16 weeks, it is very important for these patients, apart from the history and evaluation, should be monitored with the cervical length measurement. The first thing to do for the cervical length measurement is 16 weeks onward. Is as per the NICE guidelines, it is weekly or twice weekly based upon it's a low risk or the high risk. And any time you get the cervical length to be less than 25 millimeter, it is an indication to start with maybe required for the encirclage operation. But if it is above 25 millimeter, the vaginal progesterone has to be offered to all women in such case. And therefore, not only this is a ultrasound monitoring, but also she needs to be monitored as per the preventable risk factors for the preterm birth and the risk factors for the premature rupture of the membrane, like urine.
Okay, Lisa, one quick question. She lost her previous pregnancy pretty early at 16 weeks. When would you raise the red flag in this patient? When would you aggressively start measuring her cervical length? And what do you think would be the right time to put in the stitch? Because she seems to be a candidate who's justifiable for the stitch.
Yeah, so actually, I think if she's lost a previous pregnancy at 16 weeks, we would probably see her a little bit earlier, maybe 12, 13. But I think the first thing to say is that actually, even if you do nothing in the vast majority of these women, if they've lost one baby, they only have a 40% chance that they will have another preterm birth. I know that's still a high risk, they will have one, but you know, it's not inevitable that they're going to have another preterm birth. So we've just rewritten the RCOG Green Top guidelines on cervical cerclage. They came out a few months ago. And actually, in terms of history indicated stitch, the only women that really benefit from a history indicated stitch are ones that have had 3 or more late miscarriages or preterm births. And that's not withholding a good treatment from women. It's purely from the fact that actually the majority of women will be fine without putting that in early. And in most women, you may not need to do anything, but actually just monitoring the cervix with ultrasound is sufficient to pick up those with the short cervix to get the benefit from the stitch.
How frequently would you do the ultrasound, and how early would you start looking at cervical length?
Yeah, so we potentially from 12, 14 weeks, if they're very high risk, we would do it 2 weekly. And then by the time we get to 18 weeks, we can combine that with fetal fibronectin. I realise that not everywhere uses that, but it gives us the added benefit that if we combine fibronectin and cervical length, we can get a risk that they're going to have a problem in the next week, 2 weeks or 4 weeks. So for example, if the woman's cervix is long and her fibronectin's low, then we can space those appointments out to say 4 weeks. And then we would usually discharge them from our preterm birth clinics by 24 weeks.
So whenever we have such a patient, I think TVS is the screening method in modern obstetrics. We should do TVS. You need to do it depending upon the time when she lost her previous pregnancy, and cutoffs can be variable as much as less than 2.5 centimeters or less than 3 centimeters, depending upon the population, depending upon her risk of preterm birth in this pregnancy. Obviously, we have 2 options. One, the progesterone, and second is the stitch.
Dr. Amaya, can I just ask one thing, which is my query, because now we are doing an 11 plus 13 plus 6 weeks pregnancy scan for all the women. And that specifically we are looking for the nasal bone and trisomy screening plus PIH screening is also being recommended. But high risk patient, can we look for the cervical length measurement at 11 to 13 plus 6 weeks scan also? So that can also help us in prevention.
Yeah, we do it that way routinely. We do it between 11 to 14 also. For cervical length. Yeah.
Madam, we can look for the cervical length, but like you will agree that we will put the stitch once we are sure that this is not an anomalous baby. And that would be a reassuring thing when we do a scan at around 17 to 18 weeks. So you could put her on the high risk category. You can talk to her about cerclage, counsel her, but putting the stitch would be once we are sure that there are no anomalies. So that would be slightly late.
Yeah, that is true. We will put the stitch later on, but at least we can have a follow-up of this patient more frequently to look for the cervical length. And now in the 11 to 13 plus 6, many of the abnormalities can be diagnosed. And even at 18 weeks, you can diagnose anomalous baby to giving a chance to the high-risk patients like she had in previous 1 or 2 losses. On that case, the stitch can be taken out, but once the patient goes into the labor, you can't prevent it.
We can consider giving a progesterone as early as that, around 12 weeks, of course.
Yeah, but we have occasionally taken a stitch even at 14 weeks, telling patient, explaining everything to the patient, because if she has had a spontaneous abortion at 16 weeks, sometimes by the time you wait till 16 weeks, she can go into another spontaneous labor.
That's true.
But then, so you need to counsel the patient properly, and then maybe you can take a stitch at the 14th.
Next question is to Dr. Sridhya. At 20 weeks, this patient had a cervical length of 1.8 centimeters. We also saw funneling. What would you consider in this patient? She looks to be needing a cerclage. Which method and any precautions?
I request Lisa to answer, because she does it every day in her practice.
Yeah, no, that's fine. So I agree she needs a stitch. And again, I would go in expecting it to be a McDonald, but if for any reason the cervix was flush with the vagina, we would then put in a Sridhya just to reflect the bladder away.
Okay, so we all know that as the cervical length shortens, cerclage becomes more and more justified. There could be problems in a very short cervix to hold the stitch that you could cause inadvertent rupture of membranes, bleeding, infection. The stitch could cut through, and obviously it will not work for a patient who is in established labor. Lisa already said we go in with the first line McDonald's, easy to do, more simpler, equally effective. And in those cases where we really want to have a high cerclage, more towards the anatomical internal loss, that's where the Sridhya cerclage would be of use. So the NICE guidelines, which were initially developed in 2015 and have been updated now, say that offer either a prophylactic vaginal progesterone or a prophylactic cerclage to women with history of previous preterm birth or a mid-trimester loss, and in whom the cervical ultrasound shows that there is a cervical length less than 2.5. Offer vaginal progesterone to women with no history of spontaneous preterm birth or mid-trimester loss, in whom the transvaginal ultrasound shows that the cervical length is less than 2.5 centimeters. So both are options, but you need to offer them in the correctly selected patients. Lisa, your take on rescue cerclage.
Yeah, so I think obviously you need to make sure that they don't have any signs of infection before you put it in, because the last thing you want to do is prolong a pregnancy when there's infection there for both the mother and the fetus. I think the evidence shows that they're less efficacious if the dilatation is more than 4 centimeters. And actually, when you put them in and you look at the mean time that they will prolong a pregnancy, it is only 4 weeks. So I do counsel them very strongly. And the other thing that I'm always very cautious to tell them is that, say that they need a rescue stitch and they're 18 weeks, you might prolong the pregnancy by 3-4 weeks, and then you're in potentially a worse situation because you're then peri-viable. So you might end up, as opposed to having a miscarriage at 18 weeks, you might end up prolonging it to the extent that you have a very preterm baby at 23 weeks that then has significant morbidity. So, you know, that's not to say you wouldn't put it in, but I just make sure I tell the woman that it's potentially not the salvation they think it might be.
Okay. Sarita ma'am, what would you advise your patient post-cerclage with respect to what lifestyle change? Will you continue progesterone? Which type of progesterone will you give her, injectable, vaginal or oral? And will you continue tocolytics if you had started them just before the procedure?
Well, this patient who has put on the Cerclage, in that case, of course, regarding the work-related rest and all is not advisable. It does not improve any this outcome. And of course, the strenuous work and the exercises should not be done by us. What is the routine work she used to perform, she can do. And about the progesterone, as per the guidelines we go, on that case, we can continue whatever she has been started on, whether injection, hydroxyprogesterone caproate, 250 milligram weekly, then she can continue with that. Or we can start with the vaginal progesterone, whatever is the suitable patient comfortable or compliant with the patient can we go. Because in India, the guidelines may say you go for the vaginal progesterone, but our women are very unlikely to use the vaginal and they are happy with the injectable. So looking at the patient that we can continue with the injectable or vaginal, that with the counseling. And I think there was one more thing I just forgot. Can you just go back to the slide, Dr. Amaya? Yeah, about the role of dihydrogesterone, you know, most of the people, it is one progesterone which is enough. But in routine practice, if you look into, you know, the people usually combine 2 or 3 progesterone, which is not actually indicated. We should stop using the multiple progesterone combining, especially if the diagnosis is cervical incompetence and you are put in stitches. In that case, there's no role of multiple progesterone at all.
Okay. Now, this patient took your advice. We were able to prolong the pregnancy up to 35 weeks. Dr. Srividya, she's come to us at 35 weeks with regular uterine contractions. What would you do? Would you remove the cerclage? Would you cut the knot? Would you give steroids as a rescue dose, antibiotics? Will you do a cesarean section for?
No, I think, yes, you know, if I'm convinced she is in established preterm labor, then we will remove the stitch. And then, speculum examination, find knot and cut, which is easy most of the time, but sometimes, you know, it can be a little bit of a struggle. Steroids, rescue dose, no. We have stopped giving steroids after 35 weeks. No antibiotics. If there were no other obstetric risk factors, if I have not missed anything, we will deliver her vaginally, if that's what she wishes. Yeah.
Okay. So, Shri, with all your care, she delivered a female baby, 2.1 kgs. The baby cried immediately after birth, but unfortunately, the baby developed grunting after 25 minutes, was shifted to NICU, did not need surfactant, luckily, and was shifted back to the mother after a stay of 5 days in the NICU. Lisa, we'd like you to comment on what and summarize when do you really put the stitch? Because as obstetricians, every cervix doesn't require the stitch, but on the other hand, a stitch in time will save 9.
Yes, indeed. So I completely agree with your first column. So the evidence shows that a history indicated stitch is only required in women that have had 3 or more second trimester losses or preterm deliveries. Then we would do, and also the other thing that we sometimes give it for is, say a woman has had 2 losses, but she's also had a LETS procedure. That's almost like a double hit. So I think in those women, we would use kind of common sense and offer them a stitch as well, history indicated. I think the other group that's actually quite important to just briefly touch on is women who have had a stitch in a previous pregnancy, but it's failed. So those women are suitable for a transabdominal stitch, which we would ideally put in pre-pregnancy or ATTAC. So the results came from the Maverick trial for that, and we would now do that as standard practice because they are very good. Then going on to the pregnant women who haven't had a history indicated stitch, we would monitor them with ultrasound screening. If the cervix is less than 2.5 centimeters, we would then put in a stitch. Multiple pregnancy, we would use stitches, but only, as I mentioned before, if the cervix was less than 1.5 centimeters, sorry. And as you say, we wouldn't do it just for a biopsy.
Okay. We've already discussed about this, and all the panelists strongly agree with me that every day, every hour gained in utero is going to reduce the risk of neonatal complications significantly. And therefore, we must make every effort to stretch the pregnancy as much as we can, provided the mother's health and the baby's health are kept as priority. Over to Dr. Sujata Dalvi for the third and final case.
Yes. Thank you. This lady is a 26-year-old primie, which is under our care. She had an uneventful antenatal period so far. She comes to your clinic at around 31 weeks of gestation with profuse vaginal discharge. General examination, everything is normal. Abdominal examination, uterus corresponds to 30 weeks size, uterus is relaxed. But on per speculum examination, there is pool of vaginal fluid, but internal os is closed. I want to ask Dr. Dolly, how would you go about, or how would you manage this patient?
This patient again has to be hospitalized. The vitals should be monitored. And because we have confirmed that there is leaking, but the os is closed, we can still buy time and give prophylaxis. But here we have to be sure that what is the whether she's into chorioamnionitis or not. We will get her TND count done, her CRP done. If these are raised, then maybe we avoid steroid. Otherwise, we will give her steroid. And in Indian circumstances, yes, we will consider giving her antibiotics. We will also send the high vaginal swab culture. And if we do not have facility for the neonatal, tertiary neonatal care, then we may consider shifting her to a tertiary care where the neonatal facilities are available. Magnesium sulfate, of course, we will consider in this patient.
Yeah. What about tocolysis? She has no uterine contraction. Would you still give her tocolysis as a prophylaxis?
No,
or would you not give
if
it
there
to
are
her?
no uterine contractions, I will not consider tocolysis.
Yeah. And what antibiotics would you prefer in this patient?
Either erythromycin or
Dr.
azithromycin.
Yeah.
Erythromycin or azithromycin. I will not give comoxiclav.
You will not give comoxiclav.
Yeah.
But you would give erythromycin or azithromycin.
Yes.
Okay. And how would you monitor this patient? You said WBC count and CRP levels. Patient is with you. How will you monitor, and how often will you get this WBC and CRP levels done?
Every alternate day, I will get a TND count and CRP done. And also I will do her ultrasound to see for the amount of liquor which is left, the amount of vertical pocket I can see in the ultrasound.
Correct. So ultrasound monitoring is also very important. Anybody is doing procalcitonin levels for estimation or for gauging the levels of chorioamnionitis?
So, madam, just want to make a point on procalcitonin.
Yeah, so I just wanted to ask.
Yeah, is a more specific marker as compared to CRP, but it's not a cost-effective marker. It's not routinely done. It should be only reserved when you are not getting any conclusive interpretation of from CRP or your WBC count.
Yeah,
It's
but in
also,
NICU, they routinely do procalcitonin levels because it's a better marker to find out possibility of any infection.
More useful.
I just want to mention the procalcitonin is not for the simple infection. Actually, they look for the septic syndrome, sepsis bundle care. They want to assess the severity of the sepsis. So if the women already manifest with the features of the chorioamnionitis, then the procalcitonin level may be having some role, but the routine diagnosis of chorioamnionitis, I don't think it has any role.
I don't know if it's helpful, but I've got quite a useful slide, which just from another presentation, if you want me to share it briefly, which just shows the sensitivity of specificity of various markers and their role in detecting chorioamnionitis. I can put it up briefly if that's helpful for anybody.
Yeah, you could say that, no? Do you all still do procalcitonin levels, or you all just stick to WBC count and CRP levels only?
No, it's just white cell count and CRP. And I think the other thing just to mention with that is you have to be careful, because obviously if you give steroids, the white cell count will go up afterwards. So you have to kind of interpret it with caution. The other thing that we are doing,
it does come down after 3 days, right?
Yeah. So you can do the neutrophil to lymphocyte ratio as well. So if that's more than 6, then the evidence is coming through that actually that's quite a good indication of chorioamnionitis as well. There have been some recent publications about it.
Yeah. Ameya, the next one, I think magnesium sulfate, we have already discussed.
I just want to make a point about antibiotic therapy. We need to use a judicious antibiotic therapy. 3 important things: the correct antibiotic, the correct dose, and the correct duration. Because if we use this, it is proven beyond doubt that antibiotics help in prolonging pregnancy in these situations, and they reduce major neonatal morbidity. We've already said about this, and everybody agrees that the first line would be oral erythromycin. It has to be given for at least 10 days, or the woman goes into labor, whichever is sooner. And we do not offer co-amoxiclav because it is associated with necrotizing enterocolitis. This is about intrapartum antibiotic prophylaxis. I think the speaker on PROM very clearly told us that if there is intrapartum need for antibiotics against a GBS positive woman, we have to switch over to penicillin or the other intravenous antibiotics like cephalosporins or even vancomycin or clindamycin in patients who we can't use penicillin. I'd like to ask first Dr. Lisa, what is the rationale for conservative management at 31 weeks? Do you think we should go in for delivery? Lisa?
Well, I'm so sorry. I just missed the question.
The question is that do you think there is a rationale for conservative management at 31 weeks in PROM, or we should go ahead with delivery?
No, I think absolutely there's a role for conservative management, but they have to have no signs of infection in the mother. But I think that is the challenge, because we don't have a test for fetal compartment infection. Yet we know that of babies that are born with chorioamnionitis as evidenced by placental histology, 1/3 of those babies will have had no signs in the mother at all. So it's an absolute challenge, and we really need a way to test it, but we don't have one at present.
So the factors that we need to look at are the NICU availability, fetal well-being, professional age, maternal condition, and importantly also parental wishes. All these factors need to be kept in mind.
Dr. Can
Dolly,
I just add on to this also?
Yes, sure,
Yeah.
madam.
Yeah, Dr. Sarita. Dr. Sarita?
Steroid covered and neuroprotection received. If she is not steroid covered, in that case, I may like to continue, prolong the pregnancy.
Okay. So, Dr. Dolly, are you convinced that magnesium sulfate is definitely beneficial for neuroprotection, and have you started giving it routinely in your practice?
Routinely, I've started using magnesium sulfate for neuroprotection, the loading dose, and then the maintenance dose of 1 gram per hour for 24 hours.
And we have to monitor
the patient for patellar reflex, the respiratory rate, and the urine output.
Okay. Sarita ma'am, when would you go ahead with obstetric intervention in this patient?
Yeah, of
she's
course.
37, 30. Yeah, she's 31 weeks PROM.
You mean to say on that case, or it is like how long I can continue with the pregnancy?
No. You
Lisa
have to deliver
Lisa already told us that we should continue as far as possible, provided the mother and baby are okay. But when would you intervene as an obstetrician and think that, yes, I need to terminate this pregnancy?
Yeah, not beyond 37 weeks. I would like to continue with the pregnancy, because it is always better. 37 weeks, good enough lung maturity is there, and most of the babies
that is
can
fine.
be
Up to 37 weeks, we would definitely want. I'm asking at 31 weeks, when would you think that, no, I don't think
okay.
Baby inside, it's better we take.
So, of course, if you look for the CTG and you're getting a changes of the fetal heart rate, if there's an evidence of any infection, if there's any congenital anomaly, if the intrauterine death may also be there, or some medical obstetric risk factors are there, like an abruptio, antepartum hemorrhage, severe preeclampsia, preeclampsia with the severe symptoms or uncontrolled GDM and all these cases, or some medical disorders which is not asking for which patient cannot be continued further, will terminate the pregnancy at 31 weeks. But of course, I will think for what is the NICU facility available as set up, and because this baby is going to require a good care, and of course the patient needs to be counseled about the NICU care and the cost of the postnatal care to these babies.
I want to ask Dr. Srividya, what are the difficulties that one encounters whenever you're doing a C-section for a preterm fetus, like 31, 32 weeks? Anything different from?
I think, it's not as difficult as the ones before 28 weeks, because there is reasonably lower segment is formed. So if it's a cephalic presentation, usually we don't have problem. If it is a breech or transverse presentation, and if there is oligoanhydramnios, then that is, we can expect difficulties in malpresentations. What I usually do is, before going in for section for these cases, I ask the anesthetist to keep their GTN spray ready. So, when you have had a good exposure, and if you can't deliver, it's more like the obstructed labor, ask them to give the GTN spray, wait for 10 seconds, and the uterus relaxes, and that gives you a little bit of space to, go further up to go for the feet. I think that's the main until the delivery of the baby. And after delivery of the baby, if there is significant chorioamnionitis, they are also at risk of PPH and infection. Anyway, they will be on therapeutic antibiotics at this time if they have developed features of chorioamnionitis. Because the one thing important is, once we diagnose chorioamnionitis, whatever prophylactic antibiotics they were during labor, for example, Ben is not enough, and we will usually give some stronger antibiotic. That varies between hospitals. We usually have agreed with our microbiology department what antibiotics based on the flora that we have. And interestingly, in my hospital, the treatment for chorioamnionitis is amoxicillin and co-amoxiclav, even though we are worried about the necrotic enterocolitis. But I think by then, usually, once you're diagnosed chorioamnionitis, the baby is going to be delivered sooner. So that's what we give. And in those who are allergic to penicillin, clindamycin. After delivery is mainly the anticipation and prevention and treatment of PPH. And these women usually post-operatively, they do develop sepsis, and as a result of sepsis, paralytic ileus. So they have to be monitored closely, more than other routine cesarean sections we do.
Anybody on rescue dose of steroid? Anyone can speak? Dr. Dolly?
Not in this patient, because she has leaking. So not in this patient, I will not consider rescue dose of steroid in this patient.
So which are the patients you would, if at all, you have to give rescue dose?
Ma'am, those patients where there is no leaking and the preterm labor subsides, only then I may consider. Generally, I do not consider rescue dose of steroids.
Yeah, I would tend to give the rescue dose if it's been more than 7 days since the first doses and they're under 34 weeks. But we would only give it like literally if they're about to deliver. So you wouldn't give it, if they just present again with contractions or whatever, they'd have to be actually in active labour that we would give the rescue dose at that stage.
Okay. Maybe we'll ask Sarita ma'am, because she's held such important posts and heads the administrative and research wing at the AIIMS. Madam, in your vast experience, what do you think would be the key interventions that will reduce neonatal mortality in the future? We all know that SDG goals are there, and we want to bring down, because the top 3 causes of neonatal death are still prematurity, complications during birth, and severe infections. Sarita ma'am. I think we've lost her. Maybe we can ask each of the panelists one by one. We'll start with Dr. Dolly. Dr. Dolly, what do you think would be the first? We can't hear you.
Dr. Dolly, you need to unmute yourself. Yeah.
It's very important that we consider all the aspects of the neonatal morbidity, like preterm labor or some anomalous fetus. All these things have to be taken into consideration. A good antenatal care is important, and particularly in preterm labor, when we know the history, we should take precautions from the second trimester itself to avoid preterm labor in these patients who give history of previous preterm labor.
Okay. Dr. Srividya?
Dr. Srividya, you need to unmute yourself. Unmute.
Yeah, sorry. What was the exact question? Sorry, I was trying to attach.
How do you reduce the...
How will you reduce?
Yeah, from a public health strategy, what would you think is important to reduce a strategy to reduce neonatal morbidity?
I think it's
mortality.
I think it's a very timely question, because in the UK government 5 years ago, they brought about a concept of Saving Babies Live Care Bundle. And I think one of the components of that is the reduction of the preterm birth. And I think, you know, those in the West, obviously the smoking is a major risk factor. In India, it's only mainly in the metro cities. And the second thing is mainly optimum timing of the steroids and the magnesium sulfate. And of course, the screening, prediction, and prevention. And that's why, you know, the preterm birth has almost evolved as a subspecialty in bigger hospitals like ours. But now that has also extended to all the other hospitals, where they are all developing dedicated preterm clinic, where these women who are at high risk can be managed. So I think the UK government has set a target of reducing the death due to prematurity from spontaneous birth from 8% to 6% by 2025, as Professor Shannon had explained in his talk. So it is a sort of a multifaceted attempt. It's not just focusing on one. There's a lot of public health education and the training of midwives in the UK, in England, in India, with the general practitioners as well. Have to be educated so that they refer to the obstetricians at the right time, not too late.
Okay, Lisa, your take?
Yes, I think certainly there's a lot of studies that have now come through that actually having specialist preterm birth consultants and specialist clinics also makes a big difference to preterm birth rates, in addition to the timing of interventions, and also making sure that you have people that can put in Sridhya sutures. I suspect it's probably not so much of an issue there, but certainly in the UK, things like Sridhyas, not everybody can do them. So making sure you've got cover kind of 24/7 to be able to provide that service.
So as I conclude, the important take-home messages this evening are prematurity is the leading cause of neonatal morbidity and mortality. All of us agreed that there should be a risk-based approach to screening. The patients at most risk for preterm labor are those with the previous history of preterm birth, a short cervix detected on sonography, and those with multiple gestation. TVS is recommended in all pregnancies as a routine test. Appropriate preconceptional and antenatal care will optimize maternal condition and reduce the risk of preterm birth. Guidelines across the globe support progesterone treatment for prevention of preterm labor, as it clearly shows benefit. Cervical cerclage has a role in those with a significantly short or traumatized cervix. Appropriate and timely use of tocolytics, steroids, and antibiotics form the mainstay of therapy in preterm labor. Tocolytics should be chosen after assessing any contraindications and solely with the purpose to gain time for pulmonary maturity. Neonatal outcomes clearly show benefit with NICU care, in utero transfer, steroids, and magnesium sulfate therapy for neuroprotection. Preterm birth has long-lasting implications on adult life, financial resources, and most importantly, even the emotional state of the parents and family. So there are three main strategies: prevention of preterm birth, care of management of preterm labor, and last but not least, care of the premature baby. With these three key strategies, if we are able to optimize care in all these three, we will significantly reduce preterm birth and the mortality will reduce amongst babies born preterm. To end, I quote Ban Ki-moon, the UN Secretary General, who said, "Let us change the future for millions of babies born too soon, for their mothers and families, and indeed for the entire countries. Enabling infants to survive and thrive is an imperative for building the future we want." Thank you so much, all of you, for a patient hearing. I'm thankful to the opportunity I've had to release a checklist on preterm birth, as well as to develop the Indian guidelines for preterm birth and delivery, as well as stochastic in 2017 and 2019 as a part of the FOXY core team. Thank you so much.
Dr. Amey, I'm sorry I got disconnected for a while when you're asking one question to me.
Madam, the question to you was
SDG goals.
As a person with so much experience in public health and administration, what would be the most important thing that you think would be a preventive strategy or a public health strategy in reducing preterm birth and preventing neonatal mortality?
See, that is very, very important that every antenatal clinic or every obstetrician who is taking care of the pregnant patient should have a standing operating protocol to screen for the women at risk for preterm. That is very important because in very busy OPD, we don't look into that. And the second thing, when you will do, like patient comes with an abdominal pain, you know, we don't, many times it happens, our resident don't put on the hand on the abdomen, don't look whether it is really contraction or not. They just say it may be something ye to hota hi hai. So in that case, we should think that the patient can be in the preterm pains, or so we have to take it seriously. And then, of course, there will be standing operative protocol, what you talk about the prevention, and everybody should know how to manage the preterm. And now there is this need for strengthening our SNCO services. This SNCU development is very, very important. And I think now in AIMS, when we started with, we were nothing. And then now we can save even a 700-gram baby and even a baby with a 27 weeks gestation now. And we are decreasing it further. So that is very important. If an SNCU facility can be strengthened, and every public health center, may it be PHC and CSC, there should be knowing about the risk screening protocol for the preterm.
Thank you, Amey, Sujata. It was a fantastic, fantabulous panel discussion with lot of take-home messages. And as organizers, me, Jyoti, Sushma, Sri, Jyotsna is not here, and we all are really overwhelmed with the interaction which we saw today going on between the faculties and delegates, and the interest taken by the delegates, and how faculties answered each and every question. So hats off to you, all the faculties, for sparing your precious time and giving the practical take-home messages to all our audience. Jyoti, back to you. Yeah.
I think I'll give it to Dr. Sushma to.
Yeah, I would like to invite Srividya for concluding remarks first. Sri, your experience and your concluding remarks. Yeah.
Wow, I didn't realize the time going.
I mean, it's already 2.5, almost 3 hours. Everyone was mesmerized. Yeah.
Yeah, thank you all so much. You know, it was, and I think my extreme gratitude to Dr. Shrikande for your enthusiasm, you know, and it is, you have been same energetic since the first talk that I had with you, and even at the end of the day, I don't know how you remain energetic like that. I will take some inspiration. And thanks to everyone, you know, I think you all have enormous experience, and I think I felt underqualified. And that's why, you know, I'm very grateful to Lisa Storey for filling the gap. I was telling Lisa that, you know, how what a great job all of you are doing. Whereas in the UK, it's much easier. My focus is on fetal medicine. And if there is something complex with fetal preterm, Lisa is just next door to me. And I tell Lisa, you take over the care of this woman. Whereas, you know, in the setup that you all work in, you do infertility, you do obstetrics, you do gynecology, you do cancer. So hats off to you, you know, and your enthusiasm to be up to date with everything. So I think, you know, it's been an excellent afternoon interacting back and forth, and lots of attendees, you know, so that's why I think I was a bit distracted, because I was There were questions on the chat box, Q&A, and on WhatsApp, but everything was about this topic. And I think that showed how well everybody was engaged. And thanks to everyone. And I will hand over to Dr. Malik.
Yeah, thank you so much, Dr.
And special thanks to Professor Shannon and Professor David.
Yes.
They are not here, but I think, they have inspired us. And I think, that's what they do every day at work. They inspire us. And it's great to see, even with their absence, how much impact they have.
And special thanks to Lisa for patiently being with us for almost 3 hours. Thank you, Lisa.
Thank you. It was a privilege to be here.
Thank you. And over to Dr. Sushma Verma for an official vote of thanks to each and everyone from us.
Thank you, ma'am. Thank you for the opportunity. It's a great pleasure and privilege for me to be a part of this wonderful webinar. It has been a wonderful webinar packed with knowledge and evidence-based panel discussion. On behalf of Indo-International Web Series and RCOG Lesson Group, I would like to extend my sincere thanks to Dr. Lakshmi Shikhande ma'am, Dr. Jyotsna Pundir, Dr. Jyoti Malik, and Dr. Sridhya Shankaran ma'am for putting so much efforts in organizing this wonderful webinar on preterm labor and preterm rupture of membrane, their prevention and management. I would like to extend my heartfelt thanks to our respected speakers, Dr. Lisa Storey, Dr. Andrew Shannon, and Dr. Anna David, who took time from their busy schedule, especially on the day of Sunday, and sharing the facts and their knowledge. And from bottom of my heart, I would like to pay my sincere gratitude to our moderator, Dr. Amay sir and Dr. Sujata ma'am. They are wonderful. And panelists, Dr. Dolly Mehra, Dr. Vidya Chaudhary, Dr. Sarita Agrawal, and Dr. Shehla Jamal for wonderful case-based panel discussion. I am thankful to our chairperson, Dr. Lisa, Dr. M.B. Bellad, Dr. Jyotika Desai ma'am for sharing knowledge and facts. And I am thankful to Dr. Jyoti Malik for smooth conduction of the webinar. And from core of my heart, I want to thank my all delegates and participants for the webinar, because without them, it has not been so successful. And at last but not the least, I want to thank Dr. Lakshmi ma'am, Dr. Jyoti and Dr. Jyotsna for giving me the opportunity to be a part of such a esteemed platform and wonderful webinar. Thank you. Thank you very much.
Thank you, Walter Bushnell. And thank you, Jyotika and Professor Ballard, for staying with us till the last moment. I really appreciate it. And thank you one and all.
Thank you,
Dr.
Lakshmi, for giving us the
Jyotika
opportunity.
go on answering the questions which is in the chat box.
Firoz, you can stop recording.
Dr. Lakshmi, let me say.
Yes, yeah, you can say.
Yeah, thank you so much for involving